I mean, I don't think we have time to continue.
Otherwise, you have to sit there and wait exactly the time.
Good morning. All right. I would just like to say welcome. My name is Sange Barclift. I'm a medical officer with the Hospital and Ambulatory Policy Group. And I'd like to open today's meeting. As you know, today is the ICD-10 Coordination and Maintenance Committee Public Forum. This committee is co-chaired by both CDC and CMS. CMS has lead on the procedural issues, and CDC has lead on the diagnosis issues. Everything that I am going over is on pages 9 and 10 of the handout. It should also be on the screen if you're watching this through the webcast. ICD-10 PCS code proposals being considered today are for implementation October 1, 2018. Again, there are no final decisions made at this meeting, and CMS will describe some options and recommendations to facilitate today's discussion. The public can comment today at the meeting as well as in written comments, If you submit written comments, the deadline is April the 6th, 2018 for codes discussed at today's meeting. All procedure comments will be forwarded or can be forwarded to CMS's new address, and that's ICD-10 procedure code request at cms.hhs.gov. Diagnosis comments can be forwarded to Donna Pickett via their email address, nchsicd10cm@cdc.gov. And Donna's here in the audience. If you could just kind of wave your hand so everyone knows. When her portion of the meeting is beginning, she will also review dates and deadlines for CDC. April 2018, the notice of the proposed rulemaking for IPPS will include ICD-10 CM PCS diagnosis and procedure updates that were approved prior to today's meeting. August the 1st, 2018, the final rule will have links to codes to be implemented on October 1, and that will include any codes that are approved from today's meeting. Addendum items, June 2018, final code updates to the addendum will be posted at the CMS website, and for the diagnosis will be posted at the CDC website, which is found on the bottom of page 9. The next meeting is September the 11th and 12th. Deadline for submitting topics that will be reviewed at that meeting is July the 13th, 2018. Again, procedure requests will go to the CMS website, and diagnosis requests will go to the CDC website. For today's meeting, there are 3 options for participation. We have all of you here in the audience that are attending the public meeting, and of course there will be time for you to ask questions and make comments. There are folks that will be listening to the proceedings through a free conference line, and we also have participation through a free live stream webcast. We do ask, if you are on the conference line and you want to participate, that you use the raise your hand feature to notify the operator that you have a comment or question. Again, no matter how you participate, please send all written comments by April the 6th, 2018, for codes to be implemented on October 1, 2018. Today's ICD-10 PCS codes discussed for consideration will be implemented on October 1, 2018. I want to introduce Noelle Manlove. She will introduce our first presenter.
Good morning, everyone, again, and welcome. As Sangay said, I am Noelle Manlove. I'm a member of the ICD-10 coding team here at CMS, and I'll be presenting the first 2 topics to you this morning. Our first topic is called the irreversible electroporation, and it can be found, information on this topic can be found on page 11 of our agenda and handouts document. The issue is there is not a unique ICD-10 PCS code to describe hepatic or pancreatic cancer cell destruction using irreversible electroporation, or IRE. This topic was addressed at the March 2015 ICD-10 CNN meeting, and a new code request was not approved at that time. The requester asked that this topic be brought back for reconsideration. The requester has also asked that detail be added to the ICD-10 PCS for procedures that use 3 other specific ablative, I'm sorry about that, techniques: radiofrequency, microwave, and cryotherapy. Right now, there is currently no new technology application in place. Our speaker for this topic today is Dr. Robert Martin II, and joining Dr. Martin is Juan Carlos Serna, who will be available to assist responding to any questions. So, gentlemen, are you in the building?
Good morning. Thank you again. It's an honor to be back here. As stated, we were here in 2015 to discuss this important topic. As I said before, I'm a surgical oncologist and HPB surgeon who has been performing IRE for approximately 10 years for locally advanced pancreatic cancer and hepatic malignancies. We've got sort of a robust agenda, obviously a limited amount of time, but I wanted to make sure that I lay out the significant changes that have occurred over the last 3 years since we were here, and obviously the persistent coding issue that still is a significant limitation in regards to assessing quality, as well as just the overall impact that this therapy is having, and being able to track that information. As stated above, the current ICD-10 code does not allow for a specific designation of irreversible electroporation. As I will outline to you, this is a unique local ablative therapy that has very different mechanisms of action of the other thermal ablative counterparts, as mentioned earlier, RFA, cryo, and microwave. It is that unique aspect which is why we believe that a unique code is critical to being able to track that type of real-world use within the United States. Specifically, the largest amount of use is being utilized within locally advanced pancreatic cancers and pancreatic malignancies, as well as hepatic malignancies, where we think that obviously that unmet need is the greatest. Since we were here in 2015, as I outlined here, you can see the significant, what I would classify clinical acceptance of the safety and efficacy of IRE. This is demonstrated by both the significant increase in peer-reviewed publications that have come out both from the United States as well as worldwide. There is clearly clinical need and thus clinical benefit as being demonstrated by a significant rise in publications with the use of IRE for all locally advanced malignancies. If we specifically look at a cancer that is emotionally close to my heart, and that is with locally advanced or stage 3 pancreatic adenocarcinoma, you can also significantly see the enthusiasm. And this is outlined by the multicolored circles here. These 4 publications that have all been published since 2015 have demonstrated near doubling in the overall survival of locally advanced pancreatic cancer when you compare that to all standard of care, which includes chemotherapy alone or chemoradiation therapy. There is only one study outlined here from France, which was a meta-analysis with the use of FOLFIRINOX, that demonstrated similar overall survival, but the toxicity and the ability of patients to tolerate that amount of chemotherapy is significantly limited. And so it's because of this that we have seen that IRE is not a competitive therapy, but is a complementary therapy to standard of care, which has allowed us to double and triple the overall survival in these patients. More granularly demonstrates recent publications from 2016 and 2017, specifically from the US as well as Europe, demonstrating that improvement in overall survival with the use of IRE as an augmentative therapy to standard chemotherapy or chemoradiation therapy. We similarly have seen the similar amount of efficacy and benefit and safety with the use of IRE for locally advanced hepatic tumors, being both hepatocellular carcinoma, colorectal cancer, and even cholangiocarcinoma, that has also been published in the literature since 2014, demonstrating that widespread reproducibility of safety and, more importantly, long-term efficacy as measured as an improvement in overall survival and progression-free survival. So in summary of the clinical data that has been published, we've seen significant clinical literature expansion and utilization of IRE both within the U.S. as well as outside the U.S., with clear demonstrates of improvements in overall survival and even disease-free survival for patients with locally advanced disease. It is this message that obviously allows us to continue to demonstrate significant increase in the use of IRE that potentially can benefit patients with locally advanced pancreatic, hepatic, as well as other locally advanced disease. Why is this important? I won't go into this too much, but obviously pancreatic cancer, as you can see here in purple, unfortunately, since our original war on cancer in the 1970s, we've really not done a great job. We have seen a slight improvement in the overall survival, but that has been measured in single-digit months. It is very, very sobering when you are able to take a patient with a median overall survival of 13 months and push that up to 22 months and pat yourself on the back that you've done a really good job. It is that challenge that we're obviously trying to hopefully answer in the management of pancreatic cancer because of its deadliness. Currently, the unmet need is specifically not because that radiation and chemotherapy don't work. I am not standing up here as a clinical surgical oncologist and telling you that chemotherapy is bad or radiation is bad. That is not the case at all. What we are finding is that patients just cannot tolerate that type of aggressive chemotherapy more than approximately 4 to 5 months. They will get an interval response, they will get an interval of palliation of their symptoms, but then it's the next question: what do we do next? And it is that specific area where IRE, or irreversible electroporation, can be a consolidative effect because of its non-thermal, non-coagulative base method of action that allows us to treat locally advanced pancreatic cancers and not damage the vital structures, arteries, veins, or even biliary system, to allow us to control and eradicate that tumor and not harm the vital organ that it is treating. It is because of this interest, and is clearly because of this unmet need in locally advanced pancreatic cancer, that AngioDynamics has been able to get an expedited access pathway, or breakthrough designation as it will be called, in January of this year. They've worked significantly with the FDA to get that breakthrough or expedited access pathway, helped to obviously help patients with specifically pancreatic cancer to gain greater access to this therapy, to make sure that they are not excluded from this type of innovative treatment within the U.S. Along that lines, a prospective data collection and registry is planned by AngioDynamics to ensure that we can capture all of these real-world patients, to make sure that both the quality and safety of the use of this device is available. Now, specifically around irreversible electroporation, the bottom line is that very short pulses are able to damage the cell and irreversibly porce the cell, which then leads to that type of electrolyte disturbance that leads to then slow methodical cell death over an approximate 6 to 8 week period of time. It is this method of action that is not reliant on heat. And it is these pores that then allow for calcium to enter the cell, sodium to leave the cell, which then induces autoprogrammed cell death or apoptosis, and then an underlying ongoing immune phagocytosis, as demonstrated here, which occurs over that 6 to 8 week period of time. It is this rationale as to why we've been able to treat locally advanced tumors around the vital structures, because the vital structures, endothelial cells, are able to repopulate and thus maintain their integrity, but the cancer itself ultimately will turn into an acellular scar type of formation. Now, what's critical to understanding is that there is nothing similar about irreversible electroporation's method of action to its thermal counterpart, RFA, cryo, or microwave. All of those thermal-based obviously damage the connective tissue or the cartilaginous matrix, whereas IRE spares that, and IRE's effect is specifically only within the cell. It is not damaging that type of cartilaginous matrix, which allows us to treat around these vital structures. This is a distinct difference between the thermal counterparts and what makes IRE unique, because we are ultimately not claiming that IRE is going to replace thermal ablation. It is actually an additional modality that we are now able to treat patients that were never eligible for thermal ablation because of this type of coagulative and connective tissue permanent damage. The IRE system here it allows us to use 16-gauge monopolar probes, to which at least 2 are placed in parallel. You can use up to 6 based on the size of the dimensions that you are able to treat. It is customizable, which is obviously very helpful in the clinical use, such that one size is not mandated to fit all. We are able to shape based on the number of probes that we use to be able to treat both smaller lesions as well as larger lesions, which simply require more monopolar probes to be placed. The benefits of this, as I demonstrated before, is that it will damage and irreversibly electroporate the endothelium, but it does not damage the cartilaginous matrix, which allows that adventitia and lamina to maintain its integrity, and then allow for that smooth muscle cellular repopulation to occur at 2 weeks, so that we do not see those catastrophic vascular thromboses or strictures, or any other types of long-term strictures within those vital structures. Now, the rationale specifically for our request around IRE, as I've hopefully demonstrated, is that we have seen a significant advancement in the use of IRE. Specifically within the United States, there are over 60 centers that are using IRE for treatments of locally advanced malignancies. It is through this expedited review through the FDA that we've obviously demonstrated the benefits around pancreatic cancer. But the inherent challenge is that we are not able to currently capture the real-world use of IRE because of a lack of a code. And so thus, in summary, and obviously for discussion, is that the request for this type of specific code would specifically allow us to track all IRE use across the U.S., to allow us to both measure utilization, but just as importantly, to ensure that clinical outcomes, i.e. clinical efficacy, is being maintained, as I have demonstrated earlier, with a certain number of disease types. More importantly, and just as importantly, this specific IRE code will allow us to truly differentiate between the distinctly different thermal ablative modalities, as I have demonstrated to you. It is critical that IRE is separated from those, mainly because the patients that are being treated are distinctly different, and the method of action that is being utilized is also distinctly different from those thermal ablative modalities. So in summary, we obviously are up here to request a different code specifically for IRE use so that we can better track that type of clinical and meaningful use. Thank you all for your time and attention.
Thank you. Are there any questions on the floor?
Can't help myself. Jeff Linzer, American Academy of Pediatrics. While this generally doesn't affect our patient population, I have a couple just simple academic questions. First of all, in your initial slide, I didn't see if you had a relationship with the company that's behind this product.
I did. It was on that slide. I'm a consultant. I'm a paid consultant for AngioDynamics.
Okay. And
yeah.
Is AngioDynamics the only company that has this unit?
Currently, yes, sir.
And has any national societies, such as American Cancer Society, also supported this proposal?
The ICD-10 proposal or the use of IRE in cancer?
The 10 PCS proposal.
Currently now, no. There is no other national society that has supported this at this present time.
Thank you.
Hi, I'm Linda Holtzman from Clarity Coding. I'm just interested in what kind of documentation we'll see. You're laughing. You knew that was going to come up, right?
I did. I'm not laughing, ma'am. I apologize.
No, you're welcome to laugh at me. Lots of doctors do. I'm just interested in what kind of documentation we're likely to see in the procedure report or elsewhere in the record that would allow coders to differentiate this from the other techniques. I caught on one of the slides that the system is called nanoknife. Mm-hmm. Will we see that terminology, do you think, or?
And this is why I'm up here, ma'am. It is so highly variable.
Feel free to call me Miss, by the way.
Miss. Miss, it is so highly variable. You know, ultimately, I think there are some institutions that are definitely using irreversible electroporation. There are some institutions that use nanoknife. There are some institutions that are using the verbiage of their 510K approval, which is just soft tissue ablation, to which there is no methodology or no method of action. We have all agreed, really the end users, to kind of disagree because we've never been, I guess, either educated or challenged to choose one or the other because of this high variability.
You are now.
Great.
Nellie Leon, Chisane, American Hospital Association. And you know, I always have to follow Linda. One of the comments that was in the packet was that this proposal was brought before this committee before, and that commenters opposed it because the physician documentation of this procedure will not clearly distinguish the specific technique. And from your response to Linda's question, it sounds like there will still be the same problem that we had back in 2015. Is that correct?
If there is no code.
Well, but if there is no documentation, the coders will not be able to pick a code. So it's kind of like...
What's the chicken or the egg, though, ma'am? And I think we're looking for you all to help us identify a code that we should document to. Right now, there's a widespread, I think, uneducation amongst physicians, which, don't get me wrong, is a chronic problem for coders to have to deal with. I would hope that most surgeons, when given a code and told, if you're doing this, you must obviously use this code, we will then, will then follow suit. I think the challenge that we have is that we have interpretation of what we should be documenting, and thus then the coders are then equally using that variability of interpretation.
Well, physicians would not be coding ICD-10 PCS because it's only for hospital inpatient. But if, to the extent that the manufacturer of this technology could somehow try to establish a preferred terminology for this service, then your chance, because if you don't have that, even if a code is created, it will never show up in the data.
So there's established terminology, without a doubt. Irreversible electroporation is an established terminology, and we utilize that sort of time and time again. I think what we don't see is the need for putting that, or the consistency of putting that either in the operative note. It is within the hospital chart. So I would say that the terminology has been standardized because we all call it its method of action, which is irreversible electroporation. What we are hoping for is that with this support of a designated code, you could then standardize it all across the board. Because ultimately, as I said before, you're talking about 60 institutions. That standardization around that 60 institutions could occur fairly quickly if there was some general guidelines as to how we should be better both documenting and then helping.
Oh, I'm sorry, I didn't mean to interrupt.
This is Juan Carlos Stern. I'm the Vice President of Clinical Affairs and Healthcare Economics for Angiodynamics. We have seen physicians document in their op notes irreversible electroporation, IRE, and nanoknife. So to Dr. Martin's point, it does vary greatly, and I think part of the real-world evidence and our communication with FDA and our user base will naturally encourage them to use whatever terminology is appropriate for that coders can apply the code to those charts. But there are some users now that use IRE, electroporation. Hopefully that answers your question.
Yeah. My second question is, do you see this type of tissue ablation being used in other parts of the body for other tumors?
Yes, it is. It's widespread, not widespread, but it is used in other parts of the body, definitely, both in the rectum, in the kidney, other areas of soft tissue where locally advanced cancers play a problem.
But you don't feel the need to have codes reflected for those other areas of the body?
No, the code we're asking for is around irreversible electroporation. This is not a specific code specific.
No, because the proposal, in which I can ask later, the proposal looks like you're only looking for it in the hepatobiliary system and pancreas.
Just the interest of time, we wanted to present what is the dominant clinical data that supports that utilization. Most of its utilization is being utilized in either the pancreas or the liver. But you asked me, are there other areas where it's being used? And I would say definitely.
But you don't need codes there for those areas. I guess that's really my question.
I think, again, I think it would potentially help. Again, for the same aspects of that, it would allow, obviously, for both tracking of quality measures. And so I would not say to exclude those patients, be it locally advanced rectal, locally advanced GYN malignancies, we are definitely utilizing it in those patients to palliate their symptoms.
All right, thank you.
Thank you.
Moderator, are there any questions on the line?
If you have any questions at this time, please do so by using the raise hand feature, and your lines will be unmuted individually.
Okay, I'm not hearing any, so we'll go ahead and present the coding options at this time. Thank you. You might want to stay here just a little bit longer. Okay. The coding options we have are listed on the overhead. Currently, the IRE tissue ablation technique used for hepatic or pancreatic cancer cell destruction can be reported using the codes in Table 0 F5, and that's on the page, entitled Destruction of Hepatobiliary System and Pancreas under ICD-10 PCS. Ablation is a term included in the root operation destruction as physical eradication of all or a portion of a body part by the direct use of energy, force, or a destructive agent. The coding options we're presenting today, option 1 is to do not create a new code for IRE and continue using the codes from Table 0 F5. Option 2 is to create a new qualifier value F, irreversible electroporation, in Table 05F, and that is listed at the top of the page. And then option 3, create a new qualifier value, irreversible electroporation, in Table 0F5, destruction, to identify the IRE versus other destruction techniques. In addition, create new qualifier values, radio frequency, microwave, and cryotherapy in Table Section 0F5. Okay. Our recommendation, we're interested in receiving input from the public on these options. As stated earlier, this topic was initially presented in March of 2015. Following that meeting, we received public comments opposing the creation of new codes. The commenters stated that the current ICD-10 PCS root operation destruction correctly captures its procedures. The commenters also noted that physician documentation, as we discussed, of this procedure will not clearly distinguish the specific technique of irreversible electroporation from other techniques used for tumor ablation. Therefore, if a unique code were created, it would be difficult for coders to determine when to assign the code for this technology. Interim coding advice. In the interim, continue to assign codes from Table 0 F5 as described in current coding. Are there any further questions on the floor? Moderator, are there any? Oh, wait, I see one.
This is Sue Bowman, American Health Information Management Association. Just to follow up the earlier comments, I'm still not 100% convinced how clearly this is consistently going to be documented so the coders can pick it up. I'm not a strong believer in if you build it, they will come. So, so I'm still a little concerned about that, but assuming, coders out there do say they do see it and it is being documented, then I think to follow up Nellie's point, it might make more sense to consider creating the code throughout the body systems where this technology is being used instead of just limiting it to this one. And I'm not in favor of option 3 at all unless we're going to add radio frequency, microwave, and cryotherapy to all the body systems where those types of ablation can be done. I don't think it makes any sense to add those just to this body system.
Okay, thank you.
Lynn Keene, Keene Consulting, I agree with Sue. Option 2, I think, is reasonable, but Nellie brings up an excellent point, and I do believe in one and done. Why come back later and try to get the additional character for those other body systems when we're trying to capture really the efficacy of this particular technique? I think we should take the time to investigate which body systems require that additional qualifier if this is approved to go forward. And I also oppose option 3. We don't have the documentation available much of the time to capture those other qualifiers.
Okay. Thank you.
Nellie Leon, she's St. American Hospital Association. I still need to think about whether I support this proposal. I need to sort of find out whether there's documented procedures that would be able to identify this. But I think that out of all the options, my least favorite one is number 3, because we have thermal ablation in other body parts. We have thermal ablation that for years has been identified as microwave for radiofrequency cryotherapy, but I don't recall ever seeing a proposal coming through here where there was anyone thinking that there was a need to separately identify those types of ablations. So unless CMS has a record of other proposals wanting that level of detail for destruction of other body parts, then I don't think that there is a need to create, you know, all these codes where it's just going to make it more difficult for the coders. Thank you.
Thank you. Okay, sure.
Just wanted to emphasize that there are physicians who are currently documenting IRE in their op notes, and we'd be happy to submit redacted copies of those op notes into the record, if that's helpful.
Thank you. Are there any questions on the line? Okay. Oh, one more.
Jean Yoder, Leidos, supporting the Defense Health Agency. I look at this as a data analyst, and as a data analyst, I'm thinking, okay, we've got 60 facilities. We're doing this. We don't know what's going to come in the future, what other new way to make cells die, whatever. And I'm thinking that this is you know, this is a lot of work for the entire United States healthcare to teach their coders to look for this, and what is the entire United States getting out of this? And this is really something that the people doing the study, the people trying to say, hey, this is a really good thing, but they're trying to put the cost of this study on everybody in the United States, and every hospital is going to have, you know, this extra stuff to look at. So I'm just looking at it and I'm going, well, if people are doing a study, that's nice, and if it's big enough, but 60 hospitals in the United States, I just question whether the cost effectiveness of this is really worth it. I don't know. Okay.
Thank you.
Jeff Linzer, I do just have one other question. Is there a CPT Category 1 or Category 3 code that captures this information?
I can only speak for what my coder has educated me to do. I can't speak obviously for the company, but we have used 49203, the soft tissue ablation of a retroperitoneal tumor, which doesn't actually list the method of action, and it's based on a size. So that's the CPT code that we have been instructed to use in my hospital system.
Okay, thank you. I think we have no further questions. So thank you, gentlemen.
Thank you.
All right, our second topic will be cell suspension autografting. And it's found on, information about this is found on page 13 of the agenda and handouts document. Currently, there is not a unique ICD-10 PCS code to capture all cell suspension epithelial autografts. There is no new technology application at this time. There is no FDA approval. However, an application for pre-market approval was submitted to the FDA back in September of 2017. Our speaker for this topic is Dr. William Hickerson.
Thank you. And which is our, okay. Thank you. We appreciate the opportunity to present today on cell suspension autografting. It's a little different. The comment was just a minute ago, a new way to make cells die. This is a new way to keep cells alive and patients alive in the burn world. It also has some other unique characteristics. As a disclosure, I have been on the studies for the FDA studies with BARDA and all in regards to this, have done teaching other physicians how to use this, and I am on the Speakers Bureau for AVITA. Skin graft indications, as you well know, are to replace the defects that exist after the removal of skin lesions such as malignancies and scars, with burns, non-healing skin ulcers, and after trauma as well. And this is one of the standards of care we have when we look at the reconstruction ladder that we use. Autologous skin grafts themselves can be divided into split thickness and full thickness. A split thickness has the epidermis and part of the dermal layer. A full thickness includes not only the epidermis, but the full dermal component as well. And that's different than what we're using here as well that we'll get into. So for our skin grafts, you have to harvest that skin. It can be done manually, such as a technique here where we're using a Humvee knife. It can be used with an electric or an air-powered dermatome as well. You can put that on as a sheet graft where you take that and just apply it, or you can run it through a mesher where you put holes in this that will allow it to expand, to have serum and blood seep out if you have that problems, and also for our larger areas that we have to cover, it allows it to expand to cover a wider area. Once you do that, you apply it and fixate that, and then the dressings and post-operative care that go with that. I can personally tell you that donor sites hurt. 20% of my body was burned and grafted. This was the worst thing that was existing with that at that time. But not only for a 20% burn, we have plenty of skin. But as we get to have larger burns, that becomes a problem. You can't take from the face. You can't take from the hands. You can't take over a joint. You can't take from the top of the feet. So then all of a sudden we have limited areas that we can deal with when we're doing that. So we mesh that. It gives us more coverage. But in so doing, we have more scarring and functional concerns then with that scarring that leads to contractures. You also don't have problems, you have more problems with the sweating and things like that in that area. And in addition, the color match can become a big problem, particularly on the face or the hands. The difference with the cell suspension is the size. This was one of our patients that we used for our donor site. This was the RECELL suspension that we would use. So this is a lot different than that, and what we found was that in our studies, obviously the smaller area healed much faster, it caused less pain, and the patient preferred that. But 1 square centimeter will cover 80 square centimeters for us in this coverage. Now, we're in a different situation too, though, because with that skin graft, we can either put it on, we can mesh it and put it on, but with this, we have to process it. We've got to separate the cells themselves. So we incubate it in a little warmer with an enzyme for 20 to 30 minutes. It is then separated by those enzymes. Then you mechanically isolate it, and then you prepare it. To prepare it, you wash the cells that you obtain, you buffer them, then you draw it up into a suspension here to spray on. This is the spray cell technique. It is sprayed. You really don't fix it with sutures or anything because obviously it's a liquid at this point, but you've got to hold it in place. And this is a learning curve that every surgeon experiences where you've got that piece of skin, you want to put it on, you're ready to roll. That's a little different now. You spray it on, you got to make sure you hold it there. If it pools in one area, you haven't got it in some other area. So to say that you just spray it on and you don't fix it is a little misnomer. So technically, it's a lot different. But the other aspect that we found is that the dermis is required. Now then, that's an interesting aspect because we've all had CEAs that we've used for years, but a lot of us also use dermis with those. And the reason is that you heard apoptosis in the previous talk, the programmed cell death. Our epithelium goes through the same thing. And unfortunately, it has to have something to tell it to come back. And that signal exists at the epidermal junction with a protein that says, okay, you're dying, it's time more comes back and repopulates. And that's one of the things that the dermis will provide for us. So epidermis being life, dermis being the quality of that life that we can move through. We can supply that with, if you have a deep area that still has dermis, or doing a wide mesh graft that has its own dermis that is in close proximity then. And when I say close proximity, we're not talking about a millimeter or two. We're talking about it could be as wide as a 4-to-1 mesh graft as well, and these areas close in quickly. It's really a regenerative epithelial suspension. It has the keratinocytes that we're talking about for the epidermal tissue. It'll have some fibroblasts that will have an extracellular matrix, but this does not have that C64 protein that we need for the communication. And it also has melanocytes that are there that allow us to repopulate that. And you can see in this individual that had the spray cell technology here, and this is the final color match as well as the functional aspect that he's able to have. From a procedural standpoint, it's all done in the operating room. It takes about 30 to 45 minutes to make your suspensions, and obviously the patient and the surgeon is not going to separate. We're going to be right there. It can be a two-team approach where you work on the recipient bed at the same time that your partner works on the donor site itself. It is not something that we delegate. It's something that is done as a team. Cultured epidermal autografts have been around for a long time. That's the Reinwald and Green technique usually. It takes a biopsy as well, but this biopsy is full thickness. So we go through all layers, and we send that off then to a lab to be cultured. It takes 2 to 3 weeks to grow. Then it comes back, it's about 5 cell layers thick. You make sure that you take it out. It's the cells themselves are affixed with little micro clips along the edges. And you can pick this up. You got to make sure that you put the cells down rather than up. And then you staple these together as well in the operating room. So for the cell suspension technique, it's a 3-step process. You'll have the harvesting or the biopsy, which is a partial thickness. Some may call it an excision, but that becomes the difference between your excision and your debridement codes that you may have with some of our burn work as well. So the preparation of that wound bed, but this is where we take that biopsy like you saw with a small piece and then process it. We process it, and at this point, it's the RECELL device. I'm sure there'll be others in the future. And then it's applied. It may be called a regenerative epithelial suspension as it's applied, or an autologous suspension, the cell suspension that we put on. Current usage that you see throughout the United States, these are the burn units through the United States. Actually, if I put on another hat for you from the American Burn Association, there's probably only about 100 burn centers in the United States that are active. And when we start to look at this, these are the ones that are involved here, including our center in Memphis. And we've been using this with the FDA protocols. The PMA has now been submitted. We can still use it for compassionate use. And also, there's a continued access trial that's ongoing as well. But it's part of the BARDA study as well. because they have felt that this type of technique will be important for us in a disaster situation. As you well know, 30% of the patients that are involved in a disaster, whether it's natural or whether it's terror, are going to have some type of burn injury. These are the ones that stay around the longest. You have a broken leg, you have a liver laceration or a spleen laceration, they have a lengthy stay, but nothing compared to what our 70, 80, and 90% burns may have. So this will allow us to assist with that in a rapid fashion to get coverage. We feel like that it will be important to have a code so that we can track this for that use. We can know then when we look at this, if we're faced with something, we need more representation out in this area. So it's easier for us then to get that because there's no other code at this time that will allow us to follow this. And I appreciate the opportunity, and I'll be more than happy to answer any of your questions.
Do we have any questions from the floor?
Good morning. My name is Narayan Iyer. I lead the burn program at BARDA. And Dr. Hickerson flashed the slide there. I wanted to just give a quick perspective here. We are part of HHS. We are a sister agency of the HHS within the Assistant Secretary for Preparedness and Response. Within that, I lead the burn program in BARDA, which is another big acronym, Biomedical Advanced Research Development Authority. And as part of our mission is to develop preparedness for mass casualties, which can result from everything from a detonation of a nuclear device and everything that can happen from an Oklahoma City bombing, for example. As part of that, we figured that there is a need, a clinical need, working with the American Burn Association of products like this that are actually going to be critical in developing products and accelerating healing and providing in a mass casualty. The reason why this is important is what Dr. Hickerson referred in his slide, and he just mentioned briefly, but I wanted to expand on that and give you a perspective. He mentioned that there are about 127 burn centers across the country. In a mass casualty, he was saying that there is 30% of the injuries are typically burns. 30% of a large number is a very large number of burn patients who are suddenly going to appear on one day. And that is why we develop products that are going to support preparedness. So within that, in routine care, obviously these products will be used, but having an ability to build that for disaster preparedness and track that and what the products are being utilized in routine care and in disaster preparedness would be a very critical aspect of this coding. So with that in mind, I would like to keep that in consideration, because this is a government's program as well, and as part of developing this class of products. In the future, there will be other products which are also under development, but in particular case, this cell suspension for autografting is a very critical need for disaster preparedness and tracking how these products are going to benefit the people in the long run. Thank you.
Thank you. Any further comments from the floor?
Sue Bowman from AHEMA. I was just wondering if this is the term that is typically documented in the OR report to describe this kind of graft. Is it called a cell suspension autograft, or how is it typically documented?
Usually it's documented as RECELL suspension spray cell technology. And it's well documented on all our op notes at this point, obviously with the study. And as we move forward from the American Burn Association, we can make sure that that occurs as well.
Jeff Windsor, AAP. How often would this be done in an outpatient situation or a short stay surgery, or is it always inpatient?
At this stage, utilizing it for this would be as an inpatient. In other parts of the world, such as Australia, they do use it for resurfacing with pigmentation problems, such as vitiligo and things of that nature, that they will take the cells from one area and spray back on. Personally, I wouldn't feel comfortable sending them home with that. I think that they still need more close follow-up once that's sprayed on. Just because it's a liquid technique, it does not just stay like it would with fiber and glue. So I would say that it would still be a short stay of approximately 3 days in most of the hands here in the United States.
Thank you. Any further questions from the floor? Moderator, are there any questions on the line?
All lines are now unmuted. If you have any questions at this time, please do so. Your lines are unmuted.
Okay, I think we can proceed with the coding options. I'll go through them quickly for the sake of time. Okay. Currently, this is currently coded by reporting the split thickness skin harvest using the appropriate body in the table 0HB, excision of the skin and breast body system, and the qualifier is Z to indicate the skin excision is therapeutic, not diagnostic. If desired, facilities can report the application of cell suspension autografting using one of the following ICD-10 PCS codes. The first one is 3E00XGC, introduction of other therapeutic substance into the skin and mucous membranes external approach, or code 3E013GC, introduction of other therapeutic substance into subcutaneous tissue, percutaneous approach. Coding options. The first option is do not create a code. Option 2, create a new qualifier, partial thickness, cell suspension in table 0HR, which is displayed on the page. Replacement of skin and breast body system applied to the skin body part values and the device value autologous tissue substitute to identify the cell suspension autografting. Option 3, create a new code in section X to identify cell suspension autografting. Create new device substance technology value, autologous epithelial cell suspension in the table XH0 for the body part skin values, body part values skin and subcutaneous tissue. CMS is seeking public input on these options. Interim coding advice, continue to report autograft harvest and application of cell suspension autografting if desired, as shown in the current coding section above. Okay, thank you. Do we have any other questions from the floor?
Lynn Keene, Keene Consulting. I'm concerned about option 2 in the proposals. It lists this as replacement in the skin and breast, and it lists this as a device. And I'm concerned that if this was to be accepted, we would actually be applying a substance rather than using a device for replacement. And while I can understand that tracking this is vitally important, I think the approach in the current coding, where it is into skin and mucous membranes, is actually the correct approach, but I understand that provides no data. But I'm really concerned that we don't mix this in with the concept of a device, because it doesn't seem to meet the definition for me. I also don't advocate option 3, where it's a new technology. Understand that that value for device and substance and technology is a little bit more lenient. However, if you really want data, my personal opinion is always not to use section X when it should belong in one of the other sections.
Okay, thank you. Any further comments?
This is Sue Bowman. I'm totally losing my voice today. Allergies. This is Sue Bowman from AHEMA. I agree with Lynn. I also do not support Section X. And I share her concerns with option 2. I'd have to look at where else it might belong. But the other problem I have between option 2 and option 3 is wherever we put it, I think that the root operation we pick should be consistent.
Okay, thank you.
I'm Linda Holtzman from Clarity Coding. In the interest of full disclosure, I worked with Dr. Hickerson to develop this proposal and the slides. I have several questions and concerns. Right now, the proposal as written says the current coding should be to code the harvest, and then, if desired, to use 3E0. I'm concerned about if desired. Is it your intention to say that applying this, going through this process and applying this cell suspension autograft is optional to code? If that's the case, then we wouldn't be able to tell, for now, we wouldn't be able to tell the difference between someone who has a lesion removed and someone who undergoes this cell suspension autografting. And I think it's very important to be able to tell the difference, especially in a burn patient. So that's concerning to me. Okay. Also, I'd like to note that we presented options for insert or for replacement, and also presented options for using introduction 3E0. So I'm not sure why we're the current coding is suggesting using 3E0, but 3E0 was not shown as one of the options for permanent coding. It doesn't really, well, let's put it this way. I'm open to any way to identify this uniquely, either in replacement or in 3E0. Mm-hmm. But I do think it first needs to be identified distinctly. And second, I'd like to ask you to rethink the current coding, especially the if desired part, and find a way for this to be identified as it's currently being performed nationwide. Okay. Thank you.
Thank you.
Lynn Keene, I also want to follow up on Linda's comment that in the current coding, I really don't think that the option in current coding that says that this is introduced into subcutaneous tissue is appropriate, based on the clinical comments that it needs to be basically on top of dermis. Is this correct?
It's used with dermis. It's not actually placed into the subcutaneous.
Right.
No, you would, from a surgeon standpoint, you would never take epidermal cells and put it into the subcutaneous tissue. If it grew, you'd have a lot of trouble.
Right.
So it's on top of, but we also have the dermis that's there with it, with the technique that's used for the best success.
Okay, thank you very much. And so that, partnering with Linda's comment, I think this should be coded, and it currently should be coded with the first code that's listed there into the skin and mucous membranes, and we should eliminate that option of into the subcutaneous, because as here in the current coding, Linda, it has an option of introduction into subcutaneous tissue. That would provide wrong guidance to the public, because Dr. Hickerson just said we would never do that. Thank you.
Thank you. Any further questions? Moderator, are there any questions on the line? Okay, all right, well, thank you. Our next topic will be presented by Dr. Hava Sheffield. Dr. Sheffield?
Okay, if you can turn to page 16 of your handout. Our next topic is the insertion of the Remedy phrenic nerve stimulation system. And we have Dr. Robin Germany and Spencer Bailey to present us with this topic today.
Thank you very much. I am not Dr. Gupta, who got held up in travel issues yesterday, so I will be presenting for him. I'm the Chief Medical Officer of Respicardia, and I'm a clinical assistant professor at the University of Oklahoma. And I am very well aware of the techniques here today. So the remedy system was developed to treat a disease called central sleep apnea, which is different than the more common obstructive sleep apnea. It results from a delay in the brain to respond to carbon dioxide levels. So these patients actually just stop breathing. So the remedy system itself provides unilateral stimulation to the phrenic nerve to restore that breathing. It includes a transvenous stimulation lead, which is what we're going to talk about today, as well as a sensing lead that goes into the azygos vein. It resembles a typical neurostimulator or a pacemaker defibrillator, as you can see. And again, it provides this stimulation to the phrenic nerve to move the diaphragm and restore a natural breathing pattern. It comes on automatically at night. It treats the patient throughout the night, and it shuts off in the morning when the patient gets up. We do have PMA approval from October, and as you can see here, the primary effectiveness endpoint was met, as were all 7 hierarchically tested secondary endpoints. The primary effectiveness endpoint was a comparison between the proportion of patients who had at least a 50% reduction in the number of events per hour. The primary safety endpoint was a 91% freedom from serious adverse events related to the device, the procedure, or the therapy. And there were statistically significant improvements in all of this central sleep apnea indices, as you can see here, which have been maintained now out to 18 months. So today I'd like to show a case of Dr. Gupta's, which was a 43-year-old man who presented fairly typically for these types of patients. He was very fatigued. He was unable to work because of severe fatigue. He actually stopped breathing 48 times every hour for about 27 seconds per episode. This procedure was part of the clinical trial and was done in 2013. So there are two different places that the stimulation lead can be placed. It can be placed either in the right innominate, or also called the brachiocephalic vein, or you can place the lead into a vein called the left pericardiophrenac vein, which runs along the outside of the cardiac silhouette. The procedure looks, to begin with, similar to a pacemaker or defibrillator placement. A small incision is made, usually on the right side of the chest, about 1 inch wide. A pocket is made, and you get vascular access similar to that for other transvenous leads, like a defibrillator lead or a pacemaker lead. The left pericardiophrenac vein is the one we choose because of the proximity to the nerve itself. It runs in the same bundle, and this allows very low energy levels to be delivered and improves the battery life. So once the access is gained via needle, a wire is threaded through that needle. Typically, because most of the time we're going on the right, we actually cross over with that wire through a sheath. And once that sheath is in place, then we deliver small amounts of contrast, looking for a very, very small vein called the pericardiophrenac vein. And as you can see here, this is actually what we're looking for the pericardiophrenac vein. They're very small anomalies that sit on the bottom of the left brachiocephalic vein. And once that's identified, then we use contrast and very small wires to access this. As well as an inner sheath. So we'll feed an inner sheath and very small wires to identify this very small vein. Unfortunately, in the area of the pericardiophrenac vein are a number of other veins. So this particular vein that was identified first is a thoracic vein, and that's not the target vein. So again, we have to come back out with a subselection catheter and go and look again for the pericardiophrenac vein. Here's actually the location of the pericardiophrenic vein. Once you're in, it's fairly identifiable because it runs along the outside of the heart. It actually moves with the heart. So it's easy to identify once you get there, but it can take a significant amount of time to get there. Once that wire is in place, the specialized lead actually feeds over the wire to go down into that vein. After this is placed, then we actually use a very specialized cutting technique to remove the sheath from the outside of this lead. Following that, we place the sensing lead, which goes into the azygos vein, and there are codes for that. And the sensing lead is also introduced using an outer sheath. There we go. The final steps of the procedure, again, are like other implantable transvenous devices. The leads themselves are then hooked up to the device itself. The device is then placed in a small pocket in the right side of the chest, and the device is secured to the muscle, and then the pocket is closed. And this is actually a picture of the device once it's in place. You can see on the left side the very small wire that is there along the outside of the cardiac silhouette. And then the sensing lead is the darker lead that goes posteriorly, which identifies respiration. And then on the right side then is the pulse generator. So currently, as I said, there were 2 locations for implantation. The other lead is actually planted in the right innominate vein, and that lead delivery is extremely different. So that lead is delivered via a stylet. It's placed through an outer catheter. That outer catheter is still accessed through a similar needle with that outer catheter, but then the lead is pulled in, a stylet is then pulled out of that lead, and the lead is just delivered right there. So the differences between the 2 locations first are size. So the right brachiocephalic or the left brachiocephalic are about 22 millimeters in diameter. The left pericardiophrentic vein, in contrast, is about 1.8 millimeters in diameter. It's a very, very small vessel. The right lead does not require an inner sheath, and the right lead uses a stylet in comparison to the left.
Should have mentioned earlier that there was a new technology application submitted for FY 2019. With respect to current coding, the following codes are used to report insertion of the components of the remedy system. 0JH60DC, insertion of multiple array stimulator generator into chest subcutaneous tissue and fascia, open approach for insertion of the implantable pulse generator in the pectoral region, as well as 05H03MZ, insertion of neurostimulator lead into azygos vein, percutaneous approach, for transvenous insertion of the sensing lead into the azygos vein, as well as 05H33MZ, insertion of neurostimulator lead into right innominate vein, percutaneous approach, for the transvenous insertion of the stimulator lead into the right innominate or brachiocephalic vein, or the 05H43MZ, insertion of neurostimulator lead into left innominate vein, percutaneous approach, for transvenous insertion of the stimulator lead into the left pericardiophrentic vein. We'll note that according to the ICD-10 PCS coding guidelines, where a specific branch of a body part does not have its own body part value in PCS, the body part is typically coded to the closest proximal branch that has a specific body part. The left innominate vein is the closest proximal branch of the left pericardiophrentic vein. So the current the coding options are to not create new codes for the insertion of the remedy system stimulating lead into the left pericardiophrentic vein, and instead continue to code as in current coding. Option 2, in table 05H, insertion of the upper veins body system, create a new qualifier value, pericardiophrentic vein, for the body part value innominate vein left, and the device value neurostimulator lead. Option 3 is to create new codes in section X, new technology, to identify the two major components of the remedy phrenic nerve stimulation system. In table XHH, insertion of skin, subcutaneous tissue, fascia, and breast, create new device value implantable phrenic nerve stimulation device generator for the body part value subcutaneous tissue and fascia to capture insertion of the implantable pulse generator. In table X2H, insertion of cardiovascular system, create new device value implantable phrenic nerve stimulation device leads for the body part value azygous vein and right innominate vein or left pericardiophrenec vein to specify insertion of the sensing lead in the azygous vein and the neurostimulator lead in the right innominate vein or the left pericardiophrenec vein. CMS is interested in hearing input from the audience with respect to these options.
Nellie Leon, she's St. American Hospital Association. As Lynn already mentioned earlier, whenever possible, we should try to stay away from a Section X and put new procedures within the root operation where they belong. And it looks like you have considered putting it into the 05H table. So I would prefer that option to option 3. However, I'm also very concerned about the option 3 that has X2H, a body part value that seems to break with PCS structure, where you're putting in 2 or 3 different veins into one body part value. I don't remember seeing anything like that where you have this, you have some that are this and that, but not this and that or. And so I'm not even sure why this was created if you really were thinking about putting it in section X, because theoretically, Section X would have a lot of room to create separate values for, this vein with that vein, but, not having to lump 3 different veins into one option. I mean, as a coder, if I would look at this, I wouldn't even know what I'm supposed to do with this. Do I have to have all 3, or can I just mix and match? I mean, this was really concerning because I thought if this is the way that we're thinking about going with a section that was newly created that would have the ability to expand much more easily than any of the other tables, and we're already doing this, we're in big trouble. Thank you.
Thank you.
Lynn Keene, I have to totally agree with Nellie. I understand that it seems like you're trying to get down to the least amount of codes to try to describe this. But I think it's important to mention that we have worked very, very hard in this country in the last 5 years trying to get coders to understand that when there are devices like this, where there's a business unit that gets put into the subcutaneous and there's a variable number of leads, we code to where the lead gets placed, to where the tip comes to rest. And I think that the coders of this country are now expecting to code these the same way for each of these units that do work in the body. And by putting this into Section X, we would now break all of those patterns. And I agree with Nellie that the coders would be terribly confused as to why this looks different than all the rest. I can understand if there's a new technology application that you need a unique way to identify it, and therefore I think option 2 would be the best, only because of the need to uniquely identify it for new technology. Otherwise, I don't even know that the qualifier is required based on the guideline, but I see the data need.
Thank you.
This is Sue Bowman from AHIMA, and I agree with everything Nellie and Lynn just said, and would say that I am just vehemently opposed to option 3. I think this really breaks with the structure and conventions of PCS and really goes down a bad road.
Thank you.
I'm Linda Holtzman from Clarity Coding. I'm unhappy about option 2. So that's a little different, right? I'm very concerned about specifying for the device that it's a phrenic stimulation device. You know, every other kind of neurostimulator in ICD-10 just says neurostimulator generator or neurostimulator lead. And if we specify phrenic nerve stimulator in a device column, I can see every single type of stimulator, you know, saying, hey, they got their own code. I want a code for spinal, brain, sacral nerve, occipital, you know, vagal, gastric, every type of neurostimulator device. So I think we need to stay with convention, you know, the established precedent in ICD-10, and just say neurostimulator generator, neurostimulator lead. If we're this specific, I think not only will the neurostimulator community want to identify distinctly, but you'll start seeing this as being cited as a precedent for, you know, my purple device number 3 should have its own personal code, and this guy's green device number 12 should have its own personal, and that's, you know, that's not really, I think, where ICD-10 should be going, unless there's a new technology application involved. So, for what it's worth.
Just to clarify, you're talking about option 2, the device column?
Oh, sorry, yeah. Option 3. Oh, so I am with everybody else on option 3.
Okay.
Yeah, we hate it. Thank you.
Thank you. Do we have any additional comments on the audience? Moderator, can you open the phone lines?
All lines are now unmuted if you have any questions at this time.
Hearing none, we'll proceed. The interim coding advice is to continue to report insertion of the phrenic nerve stimulation system as shown in the current coding. Okay. Our next topic is endovascular bypass of lower extremity arteries. We have Dr. David Deaton here to present. There's currently no unique ICD-10 PCS code to describe percutaneous lower extremity artery bypass using adjacent veins. A new technology application has not been submitted. It may be submitted for FY 2020. And FDA approval has not yet been received. The LimFlow device was accepted into the FDA's Breakthrough Device Program and received approval of its investigational device exemption, and the Detour system received conditional approval of its IDE application.
Thank you very much. It's a pleasure to be here today. I'm a vascular surgeon by training. Along disclosures, I only practice 1 week a month at the University of South Carolina. I'm the Chief Medical Officer for Syntactics. They have business relationships around clinical studies with both of the technologies I'm going to speak about today. And I also do medical device consulting, and some of that is with LimFlow, one of the companies that we'll discuss today. As most of you know, atherosclerosis is probably the most, is responsible for most of the morbidity and mortality in Western populations. It's a diffuse disease. About 12% have lower extremity atherosclerosis of the entire population, far more prevalent in those over 70. In its end stages, it results in limb loss. It first presents as claudication, pain with exercise, progresses to rest pain, where tissues don't receive enough oxygen, even at rest, and finally to ulceration that won't heal, and then to frank gangrene. So the treatments that we have today are in 2 broad classes. Percutaneous interventions, which are catheter-based percutaneous interventions. Those are all designed to recanalize diseased arteries. We use a variety of instruments. Balloon angioplasty is sort of the fundamental part where we dilate the artery, basically a subtotal rupture. We use stents to control the plaque. Sometimes we use atherectomy. We have cutting balloons. But all of the percutaneous revascularization techniques are recanalizing the arteries that are there. I describe my role as a vascular surgeon to patients sometimes as a plumber, and I say I'm either going to clean out your pipes or put in some new pipes. This is the cleaning out the pipes part, okay? Percutaneous intervention. When we do open surgical procedures, sometimes we do endarterectomy locally, through an incision where we clean plaque out. But by and large, what we're doing is bypassing. We're giving up on the old vessel. We're sewing a new bypass, either a piece of vein or an artificial conduit from where there's good inflow, going around the block segment and plugging it back into the preserved distal vasculature. Much in the way, if a road were destroyed, you'd go from where the road is, around the route, and back onto the new road downstream, if the bridge was out or something. Of course, amputations included in open surgical procedures when we don't have a way to revascularize patients, and some of these techniques I'll describe today are meant for these patients without other options. So in lower extremity bypass procedures, which I just described, what we're doing is exposing an inflow source, an artery proximally that does not have obstructed arterial blood flow, and then plugging it in distally. And for the lower extremities, that's always popliteal or tibial vessels. We use autogenous vein when we can. That has better results. Or we use artificial grafts, sometimes augmented by vein patches. The problem with open bypass is that it's a very large procedure, and even this picture here that shows some small incisions is not usually accurate, at least if we use vein, because we usually have to make an incision all the way down the leg. And so a large number of patients develop some sort of complication in the postoperative period, often a result of those wounds. So what is endovascular bypass? Endovascular bypass takes elements of both of the things that I've described. It is percutaneous, catheter-based, but it doesn't recanalize, it does a bypass, like we do with open surgical bypass. And so that's basically the thing that distinguishes it from those two other broad categories. And there are two current forms. Both involve creating a connection between the artery and the vein, and also deploying stents or stent grafts. These are covered stents. One supplies blood distally into the venous circulation of the foot. One uses the vein as a conduit. When we do a bypass, it's also extra anatomic. We tunnel through subcutaneous tissue. Here, so that we don't have to create those long incisions, we're using a vein in one form, and I'll describe both of these in a bit more detail for you. So in technique A, which is called the limb flow procedure, that's the name of the company developing this, a catheter is placed into an artery down to where it occludes, and then another catheter is placed in a parallel vein, usually in the tibial circulation. Using that ultrasound guidance, you use a needle that goes from the artery into the vein, and then you create a connection, first by ballooning that area, and then eventually putting a stent graft. And you use the vein as a conduit, as a place, so you can run that stent graft without putting it in subcutaneous tissue all the way down to the ankle. I think we have one more slide. And then use antegrade valvulotomes. But we're putting arterial circulation at the level of the foot into the venous circulation to supply oxygenated blood to tissue when we don't have a runoff target. We don't have a place to land a bypass. We don't have a way to recanalize vessels. And these are usually what we call no-option patients. The stent graft itself is doesn't bear the structural requirements of an open bypass because it's inside a vein. We just need it so that it doesn't leak that blood into the side branches of the vein, and so it is not opposed by the valves. And when we get to our destination, we want it to go into those branches, and we destroy the valves so the blood can go in the opposite direction it normally goes. I like to use analogies, but you can sort of think, if there's a hurricane in Charleston, they take all 4 lanes of the interstate, they reverse the traffic and say, there's no traffic going to Charleston, everything's going out. The second technique is called the PQ bypass or the detour technique. And here, this is being used to provide a minimally invasive option to do a bypass like we would do with open, but using catheters. As you know, many of our patients with atherosclerosis die from heart attacks and strokes. All the patients we treat have generally critical atherosclerotic disease and all of these other atherosclerotic beds. So this is trying to get the value of bypass with the minimally invasive part of catheter-based. And here, you go down again to the level of the occlusion, you cross into the vein, and then from below you come up and to where the vein, where it reconstitutes and in the artery, and then cross back over so that your bypass runs from the inflow, not into subcutaneous tissue, but down a deep vein and then back into the artery distally. So it's completely analogous in function to an open surgical bypass, but it's done with percutaneous catheter, based techniques. And these connections we're going to describe this a little bit more, but we use a lot of terminology, as we do for everything that's catheter-based. We use balloons and stents as methods. In the same way in open surgery, we would say we were going to clamp or suture. They aren't procedures, they're techniques used to complete a procedure. But this is the end result in the bottom frame of a PQ bypass or detour procedure. Inflow around an occlusion, using the vein as the way to get the bypass down, and then re-entering the artery or outflow vessel. So balloon dilatation is performed because we can't cut the artery and vein open with a knife. We use a balloon to dilate those areas. We sometimes use it to dilate the vein prior to stent deployment, and then use it to expand the stents to their full extent if there are limitations because of valves and that sort of thing. And we generally call this angioplasty. Angioplasty in its most formal sense. We can do open angioplasty with surgical techniques. We can do balloon angioplasty, but angioplasty means just to change the shape of a blood vessel. Here we're using balloons. Other times we use a knife or patches, a variety of things. And the stent, as opposed to when we recanalize vessels, where it's holding back the fragments of balloon angioplasty or trying to hold open a vessel, here it's just being used as a conduit in the same way we would use it as a surgical bypass. And it's either used so we don't lose all the arterial inflow into the venous circulation in a way we don't want to. So both techniques, the limb flow and the PQ bypass, need a covered stent graft so we don't just create an AV fistula. In these procedures, they're often be documented as an anastomosis in the same way we would do an open procedure. And the artery vein connections will be described as an AV fistula, at least in their creation. We are going from an artery into a vein. We're creating a connection, but we're not doing that in the conduct of trying to mature a superficial venous circuit to do hemodialysis access, because we're not just doing an AV fistula. AV fistula is a component, just a necessary part of creating this endovascular bypass. And then both of these techniques use specifically designed stent grafts to achieve these. They don't use any other commercially available stent grafts because they have to be specifically designed for this purpose. So, and this is where I'm a little bit out of my water because, as you know, I'm a physician, I'm not a coder. But I think some of the arguments for creating unique ICD-10 PCS codes include the identification and differentiation of these procedures from the two alternatives, conventional open procedures or endovascular procedures. It will be necessary to track the utilization of this technique within the broad variety of other revascularization techniques. and also to understand where the outcomes are clinically meaningful to the patients that we are trying to treat. And that will then go towards what our national societies do in issuing guidelines and consensus statements about the best way to treat patients. I'm a member of the Society of Vascular Surgery and have worked with guidelines committees and all of our societies that treat these patients. It's now a broad group of specialties, radiologists, cardiologists, vascular surgeons, to use evidence-based guidelines. But if we don't have the ability to collect the evidence, it's very difficult for us to understand sort of what's happening in the real world. So being able to track and differentiate these procedures from the two broad categories of endovascular recanalization and open surgical bypass, we think will be critical to that effort. And I'm glad to answer any questions and defer questions that I don't know the answers to others in the audience. No questions? Thanks very much. Do you want me to stay up here?
Sure, just in case there's any follow-up. There are no unique ICD-10 PCS codes to report percutaneous peripheral bypass of the lower extremities. To report these procedures, facilities may use the percutaneous endoscopic approach, which is the closest approach available in Table 041, the appropriate body part value, and the device value synthetic substitute. Alternatively, code percutaneous lower extremity artery bypass using adjacent veins to the root operation 04Q, repair of lower arteries, using the appropriate body part value for the artery bypassed from and the percutaneous approach. Official coding advice published in AHA's Coding Clinic for ICD-10 has often recommended the root operation repair for bypass procedures that could not be captured accurately using the values currently in their ICD-10 PCS tables. However, this coding advice is typically for cases where the desired qualifier is missing from the tables rather than the approach. To our knowledge, there is not a published default coding convention recommending using an endoscopic approach for a procedure performed using a percutaneous approach. The coding options we are presenting: option 1, do not create a new code for a percutaneous lower extremity artery bypass using adjacent veins. Utilize the current codes as described in current coding. Option 2, create new codes in Section X, new technology, to identify percutaneous bypass of lower extremity arteries using adjacent veins. Option 3, add the approach value percutaneous to Table 041, bypass of the lower arteries body system for the lower extremity body part values, the device value synthetic substitute, and the qualifier lower extremity vein to identify percutaneous bypass of lower extremity arteries using adjacent veins. Our recommendation is option 1, do not create a new code for percutaneous lower extremity artery bypass using adjacent veins. Utilize the current codes as described in current coding.
Nellie Leon, Chisane American Hospital Association. Number one, I guess I don't understand why your recommendation would be to do nothing, because I don't understand why option 3 does not work, why you would not consider adding a percutaneous approach. But more importantly, I'm very concerned about what's listed here as current coding. And just sort of give you a little bit of background in terms of how this could potentially create a lot of problems today, even as we speak. When coders don't see something that fits what they see currently in the PCS classification, one of the options could be to see if there's a proposal for a procedure. And when there is no new code, you could say, oh, well, this is what CMS is saying is the current coding. So until something is done, this is what I should be doing. Current coding should never provide two different alternative options, because that just creates more confusion and it's totally wrong. Number two, the comment about coding clinic for ICD-10 has often recommended the root operation repair for bypass procedures that could not be captured accurately. The root operation repair has consistently been used to mean that it's the root operation of last resort, when there is no other root operation that would meet the definition of what's being done. And so the primary focus has been for the coding clinic editorial advisory board to try to establish that the most important thing is that you try to identify the root operation. And in the years where we had a code set freeze and you could not expand the codes as needed, we had to come up with kind of an interim solution. And so many times what we ended up doing was we would select the correct root operation and then would say, well, you know, this is what you do as the closest available equivalent. So for situations where the approach value was not available, and we have an example that was published in the third quarter 2016, and granted that it was not a bypass procedure, in that situation it was a replacement root operation. But what we said then was that the approach value percutaneous endoscopic should be used as the closest available equivalent to percutaneous. So we would not have gone totally off the appropriate root operation into repair. So I think that, not sure what your process is, if you can correct this in the document that it's on the website, because this is just going to create all kinds of problems where people say, oh, I have an option, I can choose this or that until something is done. Then my next comment, and I'm sorry I'm a little bit long on this, but option 2, again, this is in section X, new technology, which would not be my favorite, but I think adding a device value that says what the device is, intraluminal device, but also at the same time saying where it's going into the lower vein goes against the structure of ICD-10 PCS. We really don't have that in other codes. And I realize that you're doing that here because the qualifier value is used up, because that's where you put the value that says, oh, this is new technology, grade 4. So you're kind of trying to bend the classification to fit this in. But similar to my previous comment, I don't think that there's a need to do that sort of change going outside the structure until we are at a point like we were with ICD-9 CM, where it had outlasted its use, and we were just scrambling trying to figure out where to put things that didn't really belong, just because there was no way to create new codes. And again, this is way too early in the process to start changing PCS rules and creating things in sections that don't belong when we still have room. So I would say, based on what I've just heard, I don't see a problem with option 3. I think that would probably be the easiest and closest thing to what really is this procedure, as well as staying within the boundaries of ICD-10 PCS.
Thank you.
So Sue Bowman with AHIMA, and I agree with Nellie, and I too am very concerned about this current coding that is proposing 2 different options, and agree that I think that needs to be corrected so that coders do not review this material and think that they can just pick which route they want to go depending on how they feel. Would not be correct coding. I also support option 3. I have the same concerns about option 2 as Nellie, and also I don't like the idea of putting just one approach for similar comparable procedures over in section X, while all the others and all the other approaches are in the regular main part of PCS. I think that's very problematic and really an unnecessary way to go.
Thank you.
Hi, I'm Ting Langley. I would go with option 3. So we are telling coder that the artery veins of the legs, specifically what part bypasses with a device. The procedure always percutaneous, or it's sometimes it can be open.
Always percutaneous.
Always
Okay.
percutaneous.
That's
Okay,
the point.
so from a logic of a coder thinking, the bypass is root operation from the where we bypass it, which is the artery, device what we're going to use, and then the modifier going to be where it go to, qualifier. So if we can expand the qualifier out instead of have only one lower extremity vein, more further vein where it's actually bypassed. So the question to the doctor is only one leg vein you bypass to or other leg veins in the legs?
You're using the vein as the way to get to your destination. For one of these procedures, the destination is back into the artery, okay?
So,
just like we do open bypass.
Right.
The other technique, the destination is the veins in the foot and reversal of flow in the veins in the foot.
It is confusing.
So there's not really a surgical analog procedure.
I know. I'm a coder things a little differently. But I think what you're trying to accomplish to your technique is you want to bypass to somewhere. So
We're trying to get circulation back to a part of the body that's not getting
so
circulation.
so femoral vein occluded, you're going to use synthetic material, you bypass it. With a route, the first route you use a vein. And to go back to
the vein is the pathway to get that conduit, that stent graft, in an open bypass would be a graft, down to where we want to go. Because in open procedures, we use a big tunneler.
Right.
And just push our way through soft tissue. We don't have that option with any percutaneous technique.
So, and then the blood flow would reroute back to femoral vein, right? Because you basically bypass that occluded artery.
One technique we're bypassing it, and the other we're using the veins to perfuse the tissue down in the foot.
Right.
But we use, in both cases, the way we get the bypass, stent graft, it could just be a graft, is to use the pathway of the lumen of a vein to get there. That's how we get to our destination.
Okay, then it's still the bypass. So then there should be two different kind of code set and procedures. One, you use a vein to bypass it. So we're going to use it as a coder. We're going to follow logic how we see in the documentation. Is that you are bypassing from artery vein to somewhere. If the document tells somewhere, then the qualifier should be some whatever may be in there. So that is more logic sense to us. So the qualifier need to be expanded out provided that provider actually document where you actually bypass it to, and would make more sense to us.
Lynn Keene, Keene Consulting. I want to reiterate what Nellie and Sue said, that this document actually now should be corrected in two places. The one about the RECELL, the current coding options, and this one, because people reference these documents as the way to code when we are waiting for a solution. I also advocate option 3 as the simple and most direct way to solve this problem, simply by adding the percutaneous approach, which should have been there all along, and I think that solves the problem.
I'm interested in hearing comments about the idea of adding percutaneous would add many codes to the classification system. And this is, especially if we were to add multiple qualifiers, and this is systems that are not yet FDA approved. We don't know if they're ever going to see the light of day. We don't know if these codes will ever be used. So I'm interested in hearing comments about that. Looks like you're well suited to answer.
Hi, it's Linda Holzman from Clarity Coding, and you and I have interacted on this before. So people are going to laugh at this, but I'll keep my comments brief. First, other people have made some of the comments that I would have made, so I just want to mention on the current coding, you said you weren't aware of anything, any advice to use the closest equivalent, and Nellie pointed out that there was something in Coding Clinic, although it was about a different kind of procedure. I just wanted to let you know, I had actually written to Coding Clinic about that, specific Q&A to ask if that advice to use percutaneous endoscopic could be used across the board, or was it just limited to the valve procedure. Coding Clinic wrote back to me 6 months later and said that it could be used in other situations. And in fact, the example that I gave was this, whether it could be used here. I wasn't able to release that to you because you have to get permission from the AHA to release that kind of letter, but I did get permission yesterday. And, and I will send that to you, the letter that they sent to me. And the other point that I wanted to just, I guess, reiterate is the idea of not creating a new code here is shocking to me. And I've been a coder for 35 years, over half of that as a Blue Cross coding auditor, and I'm hard to shock. But this was really shocking to me because one of the whole purposes of ICD-10 is that if you get a new approach, you can just add a value to an existing table, which that's exactly what we're asking to do here. That was one of the ways that ICD-10 was presented to the public. So I don't see why that wouldn't happen. Now, you mentioned a concern that this is still in clinical trials or something like that, but it's headed toward FDA approval. And if CMS has some kind of new policy that you have to have FDA approval before you can request a code or before some kind of change can be made, I think you should articulate that. But that has not been the policy to date. That if you're within spitting distance of an FDA approval and the clinical trials are going in the right direction, I mean, you have to ask in advance because otherwise, you know, it does take time for this to work its way through the system. So hopefully by the time that, you know, it never aligns perfectly, but hopefully by the time that things do go into a more widespread distribution, there will be a code available. To my mind, this needs to be identified distinctly. So I'm obviously on option 3. And I forgot to mention, but in the interest of full disclosure, I worked with Dr. Deaton on this proposal, and also with LymphFlow and PQ bypass. Sorry, I forgot to mention that. So I do have an interest in this, but also as a coder, I'd have said the same thing.
Thank you.
Sue Bowman, and in answer to your question and in agreement with what Linda said, I completely agree that we need new codes here. I actually was never in favor of all the streamlining, as I know Rhonda Butler from 3M called it years ago, about trying to reduce codes and make the physician community think that there was fewer codes in PCS and make everybody happy. I always felt like every body system should have all of the physically possible approaches that can be done, even if no particular procedures at that time were being done using that approach, just so that we don't run into this situation where there's a new procedure and now we have to use an approach that isn't quite right. That was the whole point of not having, you know, others specified and those kinds of things like we had in ICD-9. So, you know, I see what you say about it, you know, it's not FDA approved yet, but to me this is just adding an approach. It's not the same thing as putting in some strange, very specific device that might never actually be implanted in the future. This is, I think this approach needs to be here, if not for this procedure, other procedures down the road that are done percutaneously.
Thank you.
Nellie Leon, she's saying AHA. In response to your question, I agree with what's been said before. Adding an approach to me is very different from saying don't create a new device code for a device that hasn't had FDA approval. I probably would have gotten up here and say, well, do we really want to do this? But creating an approach is very different for me, and I think that at this point, we don't have the concern that we had earlier about, oh my gosh, how many codes, and will people be able to memorize them, and so on. I think by now, after an implementation, people have said, have realized that, no, you don't have to memorize any codes. And it's very concerning that there is an approach that's being used with the correct root operation, and that, you know, we would stand here and say, no, don't create codes for that. I think that this is exactly what ICD-10 PCS was intended to do, to be able to identify these procedures as accurately as possible. And identifying the correct approach is one of the more basic things that could be done in the classification. Yeah, it creates more codes, but at this point, I think that it's, you know, whether it's for this procedure or any other type of bypass procedure that would use a percutaneous approach, this is the right thing to do.
Thank you. Do we have any further comments from the audience? Moderator, please open the phone lines.
All lines are now unmuted.
Hello? I'd like to ask a question.
Go ahead.
Go ahead.
Would the same code be used for both techniques that were described? If the vein is used as the bypass route, should the device be synthetic substitute?
Yeah, I'm going to defer to Lynn on that.
Did you want to speak to that, Hoffa, or?
You can go ahead.
Okay. This is Linda Holtzman from Clarity Coding. I said before that I work with Dr. Deaton on this, and with limb flow and PQ bypass. Who is the questioner?
This is Margaret.
Hi, Margaret. The intention in option 3, which has just disappeared from the screen, the intention is that, yes, both the current techniques would be able to be coded from the code table in option 3, and in fact, it doesn't show well in option 3. I'm not sure if you were intending to create a new row or something like that, but there are qualifiers available, currently available in code table 041 that are ideal for both of these procedures, so there's no need to create any new qualifiers. The only thing that we wanted to do was to add percutaneous as the approach, and then for the body part, this didn't get a lot of discussion, but to add some of these other arteries that can be bypassed, like the anterior tibial left and right, posterior tibial, and the perineal, I think. And then as far as the device goes, you're using these stent grafts as the conduit within the vein, so synthetic substitute would be appropriate and could be used with both of these procedures. Does that answer your question, Margaret?
Yes, thank you.
Thank you.
So I'll just add a comment. You know, so both of these procedures start in an inflow artery. That's in common.
Okay.
Both of these procedures use a prosthetic conduit down the vein.
I just wanted to give you a heads up.
Moderator, please mute the phone lines.
So both use an artery as inflow. Both use prosthetic grafts, whether they're supported or not, stent grafts, in both of these cases. And then the destination is being dictated by the disease state. In one case, it's an artery. One case, it's a vein. And it could be different arteries and veins. That's just a patient-specific, you know, whatever things are available to get the blood to the tissue that's ischemic.
Moderator, can you unmute the phone lines to see if we have additional questions?
All lines are unmuted.
Okay, hearing none, we will proceed to the next topic. Thank you. Our next topic is implantation of a multifunction networked neuroprosthesis. And we have Dr. Hoyen, who will be presenting with us today. The issue is that there are currently no ICD-10 PCS codes to describe the implantation of a multifunction network neuroprosthetic system to restore functional movement in the upper limb and or trunk for patients with cervical and or thoracic level spinal cord injury. The applicant is seeking separate codes for two configurations of the multifunction network neuroprosthetic system, the upper extremity configuration and the trunk configuration. There is no new technology application in place. The applicant has indicated it would be applying for that in the future, and the device is not yet FDA approved. An early feasibility clinical trial of the multifunction network neuroprosthesis is currently underway for FDA approval. Dr. Hoyen?
Thank you. I just want to first begin by saying that when I was introduced to caring for patients with spinal paralysis 20 years ago as a fellow in Cleveland, I could have never imagined being here asking for or making a request for new codes that are ICD-10 PCS for a multifunction network neuroprosthetic. But I'm really excited to do so because it will certainly allow for patients with spinal paralysis to regain use of their limbs and trunk. We believe that new codes are necessary because the current codes do not describe the unique features of this multi-function system, which until now has previously not existed. With proper new technology X codes, the utilization, implantation, and outcome data capture can be appropriately performed. We later intend to apply for a new technology add-on payment. A network neuroprosthetic is a completely implantable system, meaning that there are no external components, there is no exoskeleton, nothing needs to be donned by the patient. There's a power source that can be seen in the lower abdomen and a series of modules that connect to electrodes. These small modules record muscle signals, which in turn modulate the output and sequence of the stimulating electrodes. The number and location of electrodes is customized to each patient based on their deficits and needs. The initial system is designed to control the trunk or your torso and the hand. Just a little background. There are muscles which lie below the level of spinal injury, such as those in the forearm as can be seen on this diagram, but are also in the hands and the trunk, which can still be activated with an electrical signal. The patient cannot control these muscles, thus they're still paralyzed, but through the remaining link to the spinal elements, the neuroprosthetic multifunction system can stimulate and control these muscles in such a manner that the patients can move their hands and control their trunk or stabilize their torso. Most people are familiar with neuroprosthetic devices such as cochlear implants, spinal cord stimulators, and pacemakers, which have been around for decades. However, the NMP is significantly different. The hardware components, surgical method of implantation, multifunctionality set it apart from these other single-function devices. We acknowledge the fact that the coding for a single-function device, as we use some of these, is rather straightforward with 6 available codes based on the placement of a single electrode and power source. As can be seen in this photo, the neuroprosthetic system has a much different topology than a single-function device. The power module distributes control algorithms and power. These are through multiple pulse generators and many different electrodes. The electrodes here can be seen next to the power module with an epimesial surface electrode on the bottom and an intramuscular electrode up on the top. For the upper extremity or hand portion of the system, it's quite robust. There are 12 stimulating electrodes, 4 recording electrodes, 3 stimulating electrodes, 2 recording modules, and 5 network cables that are attached to the power source. I've had an opportunity to work with single-function devices as well as this, and the surgery for this system is also very different. At present, the surgery is much longer, it's completely open, and is done as an inpatient. It involves several surgeons working as a team. We have modeled this surgery after transplantation surgery, which also works with multiple teams. Now for the coding. The coding plan at present for the hand or the upper extremity portion of the system is on the left, and it's a comprehensive and long list of codes. Sometimes the claim form that we use doesn't have enough room for some of these codes, and furthermore, doesn't accurately depict or describe this type of technology. We are looking for a more reproducible and accurate coding method as we track utilization, costs, and outcome capture at other sites. A more straightforward coding scheme for the neuroprosthetic is on the right. There's one code for the end stream components and one code for the power module, all which are different technology than single function devices. Because this is a network system, patients may receive upper extremity as well as trunk systems. We just saw the list of codes for the upper extremity system. Now here's the list of codes that we use for the trunk or the torso part of the system. And in a similar fashion, there's 8 recording electrodes, 2 stimulus, there's a distribution of 8 stimulating electrodes, 2 modules, 2 network cables, all connected to the power module. This procedure is a little bit different as it is begun prone, and then there's a flip involved to a supine portion. The same coding issues occur in the trunk system, and the present coding system is listed on the left. On the right, the proposed code would be similar to the hand, except there's a T designation for the trunk instead of a V designation for the upper extremity. When it's put all together, it's quite a comprehensive system. This figure here depicts it appropriately. The recording electrodes are depicted in green, and the stimulating electrodes are in red. The selection of the electrodes is customized in relation to the patient needs. The diagram is really a good visual that highlights the distinction of the neuroprosthetic system in relation to complexity and functional design. Depending on the patient's anatomy and muscle response, our surgical approach involves implantation of the trunk and the hand at the same sitting or in 2 operations separated by a recovery period. The natural anatomic division between these both inpatient procedures is the hand and the trunk. The power module will be placed during one of these procedures, thus we have proposed separately coding the power module from the remaining component implantations. To review, instead of listing the multiple codes, the new coding system would provide one code for the upper extremity or trunk end stream components and one code for the power module. The system provides clarity by converting dozens of codes to 2 codes. There is also flexibility, for instance, in which the hand and trunk parts are done in the same sitting or in different operative days. Outcomes, cost, utilization can be followed for both parts in a very straightforward manner. Based on studies of earlier single-function systems and with the present implantation of patients, we can expect good outcomes for patients receiving both trunk and hand systems. We have objective data to demonstrate that patients can handle objects with their paralyzed limb or right themselves with their trunk. Independence has been documented with careful analysis. One just sort of practical example, if someone with spinal paralysis falls down when they grab something, they can't get up. They need an attendant there to right themselves. We use our trunk muscles. A multifunction system such as this would naturally stimulate their trunk muscles to sit themselves back up again. The network neuroprosthetic is a new and unique method to restore function in patients with spinal injury by enabling patients to use both their hands and their trunk. A more simple method of using 2 codes is required for the unique features and utilization of this neuroprosthetic system as it is deployed. We all understand that specific PCS codes are required in order to apply for a new technology add-on payment. Thank you. Questions?
Jeff Linzer from American Academy of Pediatrics. At what age range do you see this device being used, since there's certainly a large number of pediatric patients for a number of different reasons in addition to trauma that may benefit from this?
Yeah, so at present the label is 16 and up. That being said, with previous single diffusion devices, those at the Shrine, for instance, in Philadelphia, were implanting them as early as age 6. So if there seems to be a need, necessity for younger patients, we believe the technology is certainly transferable.
And this is a device that's already been approved?
This is under an investigational device exemption now, and we're completing the clinical trials.
So only one provider of this device?
Yes.
Okay. And I'm sorry, did you have a disclosure?
I do not. Luckily I'm the professor-in-chief of the hand unit, and I have no financial interest whatsoever. Thank you.
There is no unique ICD-10 PCS procedure code available for the implantation of the multifunction network neuroprosthesis. I'm not going to read through all these codes. We've seen that there's a lot of other codes that could also be used. So I'll just go through the coding options. Option 1, do not create new codes for the implantation of the upper extremity and trunk configurations of the multifunction network neuroprosthesis. Continue to use one or more of the existing ICD-10 PCS codes listed under current coding. Option 2, create new Section X codes in new technology to capture the implantation of the multifunction network neuroprosthesis. 2 or more codes are required to fully capture the implantation of the device. This would create new codes in Section X, root operation insertion table XHH, to identify implantation of the power module component of the device. And then create new codes in root operation insertion table XWH to identify implantation of the muscle activation component of the device. CMS is recommending option 1, do not create new codes for the implantation of the upper extremity and trunk configurations of the multifunction network neuroprosthesis. Continue to use one or more of the existing ICD-10 PCS codes listed under current coding.
I'm going for 2 create brand new codes. I do have a question. When the implantation go to a body part, would it always go to for trunk and upper extremity, or just for both?
Some of this is dependent upon the patient needs. There are those patients with paralysis that have some reasonable trunk function, so this would be more upper extremity. There are those that need both, so that would be trunk as the T and the V as the upper extremity. We're finding that most of the patients need both.
Okay, so the first option is not opera for us. We can only submit 15 codes to HHRC or to CMS. So we'll go with the new technology device. The second question I have is that, would there instance where you have to remove this device?
Removal of the device would be indicated with, for instance, complications, infection, hardware failure, those sort of things. There's not any planned or scheduled removal of the device, even in between the procedures.
Okay, so then we do need a replacement, removal or replacement code if necessary following that. So that should be added to for under new technology removal and replacement. But I think it's so many code. If we're talking about different area implantation for all ICD-10 procedure code, it'd be too much to report. I'm going number 2.
Nellie Leon, she's saying, I know you said that there has not been an application yet for the new technology add-on payment. Do you have any idea of when that might be? Because I think that's partly the concern, creating codes that may never actually go into effect. And so I'm wondering if your timeline is a year, 2 years, or farther out.
Yeah, so we're in the pathway right now, and I actually took a couple notes. We have an expedited FDA access pathway, and we anticipate FDA approval. Pivotal timeline is probably 2 years, 1 to 2 years. to complete all the data gathering. And I think this was echoed in some of the previous ones, we're trying to anticipate ahead so that we don't have this. Not only are the codes not necessarily appropriate for the type of device from a technology standpoint, it's difficult to record accurately what's been done at different operations in different centers.
Okay, thank you.
Lynn Keene, I hear the concern that this may be early for presenting this proposal, but I also recognize that the current coding is difficult and doesn't describe what's actually going on. I also do want to speak, though, to the fact that Section X may not be the correct location for this, because if down the road you get a technology add-on payment, and then that becomes the eventual state of the art, why are we simply not creating these two devices into the regular Section 0 where they're going to be needed? But I can appreciate Nellie's comment that this may be early for that. I would advocate that this is simply two device values that need to be added, and if there is the room, I think that the option that is not explored here should be considered in Section 0.
Yeah, thank you for your comment.
My name is Ron Pedraza. I'm with Reimbursement Principles. We assisted the Institute for Functional Restoration at Case Western Reserve University in the preparation of this coding request. We will certainly address the issue of whether it belongs in the X section. We'll address that in writing following this meeting, but I did want to say this morning that we've heard a lot about keeping things unambiguous for coders, making the coding and billing process consistent, logical, and easy. That's one of the big things we think this proposal does. Thank you.
I just have one last recommendation for adding new technology. Short here. So if you say some go trunk, some go upper extremity, can we add one more, maybe Y or something, trunk and upper extremity, so just make one streamlined code for the body part?
You know, we've had that into consideration to a certain extent, and you know, perhaps if it's done in a single setting, but given the fact that they may be done in different settings, yeah, we're trying to, again, as Ron has said, trying to simplify things, and there's a sort of a T for trunk and a V for upper extremity under that same thing, but I appreciate the comment.
This is Sue Bowman from AHIMA. I actually don't like the option of combining the two. As we talked in an earlier presentation, we kind of like to keep our body parts separate. And so if it's inserted in both, I'd rather just assign the two codes. That's still fewer codes than the dozens you were pointing out earlier. So,
thank you.
Any additional comments from the audience? Moderator, please open the phone lines.
All lines are now open.
Hearing no questions from the phone, we will proceed to the next topic. Thank you. Michelle Joshua, one of the nurse consultants from our coding team, will present the next topic.
Good morning. If you're following along on your agendas, we are on page 26. The next topic on the agenda is partial knee replacement, femoral modular head and articulating spacer for hip and knee joints. The issue is there's currently no unique ICD-10 PCS device value in Table 0SR to describe lateral or medial unicompartmental, unicondylar, or patellofemoral components utilized for a knee replacement procedure. Also, there is currently no unique ICD-10 PCS device value in Table 0SP to describe which portion of a knee or hip joint replacement is removed during joint replacement revision surgery. Lastly, it is also not possible to report that an articulating spacer was placed into a knee or hip joint with currently available ICD-10 PCS device values. Here to present the procedures and describe those procedures is Dr. Frank Voss. Dr. Voss?
This one. Okay, got it. Thank you for the introduction. My name is Frank Voss. I'm from the University of South Carolina. I've been working on trying to do hip and knee coding for about 15 years for ACUS and for the American Academy of Orthopedic Surgeons. I have no interest to disclose. I'm just trying to clarify and improve the coding so it's easier for hospitals to understand, coders to understand, so our registries can understand, and just to bring up some of the issues that have changed perhaps over the last 10 years to make this easier. Currently, most of our coding is dictated by CPT, and I realize that the ICD-10 PCS is different, but we want this to be as granular as possible so that the coding is clean. Some things have changed. We've recently been asked to revisit the drug delivery CPT codes, and that's because there's sort of a split between the utilization by urologists and OBGYN versus how the orthopedists use them. And so we're proposing some new codes for the fabrication and insertion of a drug delivery device. Thirdly, I mentioned that the hospital coders, registry workers who I've been trying to work with often don't know the coding or can't resolve how to code certain scenarios. And we started sort of with the end in mind. My committee basically made a list of all the procedures done in arthroplasty, and we tried to code them using ICD-10, PCS, and CPT, and we failed, to say the least. For the drug delivery device, some of these are placed in the subcutaneous tissue, but some also go into a bony defect, some into a joint cavity, and some subfascially into an abscess area. The types of drugs that can be, where they can be placed, they can be coatings on implants, they can be used in bulk, like the classic static antibiotic spacer. They can be little beads made on a wire, or you can have an articulating implant, which is usually prefabricated. The classic drugs that are delivered are antibiotics. There are some rare circumstances where chemotherapeutic agents are used. There are a few where bone growth is the goal, and sort of on the horizon there will be some that are generating bone morphogenic proteins. Some of the examples that we classically use are the antibiotic beads. The classic carrier is calcium phosphate, and that will deliver antibiotics into a local area. There are some non-reabsorbable antibiotic beads which are made on the back table during surgery and inserted. Antibiotic nail is sort of an odd device unless you've seen it. It's in the case of an infected fracture. We'll use a chest tube actually, put the rod through the chest tube, squeeze cement into the thing, and coat the entire nail with antibiotics. For the antibiotic spacers that are static, this in simplest terms in a knee would be the equivalent of a hockey puck between the femur and the tibia that would not allow motion of the knee. The articulating spacer is literally an implant taken out of a box that looks like a femoral component or a tibial component that will allow motion of the knee. That requires ligament balancing, attachment to the bone, and some things that are different than the static spacer. I have some pictures to make this easier to visualize. This is one of the hip replacement static spacers with modular heads and stems that can be cemented into the canal. This is what a sequence of a complete revision of a hip replacement looks. On the far left is the infected total hip with the well-fixed implants, then removal of the implants with an antibiotic-coated femoral stem here with antibiotics around the stem and antibiotics in the cement around the polyethylene liner. So these are completely new implants, having to dismantle the femur to put that in. And then the second stage, which is once the infection has cleared, you can put a standard implant in, which are the third implants. So classically, when we take care of an infection, there's a first stage revision to remove the infection and put in a temporary prosthesis, and then there's a second procedure to put in permanent implants again. This is a picture of static spacer. This is a block of cement, not really allowing the knee to move, but just keeping open the space between the femur and the tibia. That's as opposed to the articulating one, where there's actually femoral condyles, tibial implant, and motion between the two fragments so this knee can bend. So the coding categories that we started with our big list, where we have primary arthroplasties, we have revision arthroplasties, and related arthroplasty procedures. Within the primaries are the unicompartmentals, which is one of the focuses of what we're trying to clarify. Traditionally, the unicompartmental knees have been placed on the medial side of the knee, and that's by far the most common. They're also sometimes placed on the lateral side, and since 2006, the FDA has approved a patellofemoral arthroplasty. And those are the primary arthroplasties. There are some that require removal of some hardware after some trauma, but there's not a separate code for implant removal there. The revisions are quite a bit more complicated, and I think part of the challenge in ICD-10 is that a simple revision doesn't exist per se. You can exchange any part of the implant. You can change the modular insert, you can change the femoral component, you can add a patellar component, you can exchange the patellar component. And that explodes into a lot of revisions. The middle ones here are the uninfected ones that can be removal of any of those parts. This is the first stage infection, which would be removal of implant and a static or articulating spacer. This is the second stage for infection, which is the removal of the spacer, articulating or static, with revision to total knee. There are a few surgeons doing one-stage infected procedures, which means the entire implant removal done, washed out, closed, skin closed, drapes taken down, gowns changed, new instruments, start over with the same anesthetic, and then reimplant the surgeries, which will be also somewhat complicated to code. And then there are some revisions done purely for fracture, which are not critical to what we're doing today. On the big list, there are also some procedures in knee arthroplasty that are somewhat challenging to code. For example, the excision of scar or heterotopic bone in the lining of the knee. And we were debating how that should be best be coded. And then there are some osteotomies, which we're not focusing on too much today. These are some images. These are partial knee replacements. The medial uni here, a lateral uni placed on the fibular side of the knee. This is the patellofemoral one with a resurfacing of the trochlea and the patella. It looks like this on a schematic. This is the total knee replacement, and in revising it, you can wind up revising the patellar component alone, the polyethylene insert alone, the femoral component alone, the tibial component with the polyethylene insert, or any combination thereof, and that's not well reflected in ICD-10 PCS. This is what a hinged knee replacement looks like. This has a number of moving parts and is very different than a primary arthroplasty, in some cases replacing the entire distal femur with metal and with hinges to hold the parts together. So we've proposed that there be granularity for the partial knee replacements, and we've recommended that there be a way to code a medial unicompartmental, lateral unicompartmental knee or unicondylar knee, and a patellofemoral unicondylar knee, and that's part of the proposal. We also suspect that the implant removal is best kept within the lower joint and not within the lower bone portion, and that requires more granularity for which part of the implant is removed, rather than what's specifically taken off of the bone. And this gets a little bit more complicated. This specifies whether it's a partial unicompartmental component being removed, and that if it's a synthetic articulating spacer where that's removed, and then a different code for the static spacer. Within the spacer insertion, we should be able to specify the type of spacer inserted as static or articulating. This could be specified in character number 6. Numbers would start at 8, but it's more specifically written in the proposal that Michelle will go over. And then lastly, we debated whether there should be a separate code for hinged knee arthroplasty, which is a very different knee arthroplasty than a primary resurfacing knee replacement. And that's just whether there's a different device code for that. And then lastly, in our big picture of all the surgeries around arthroplasty is how to code for removal of scar around the knee, whether it's just removal of tissue therapeutic, whether that really represents what's being done. And that may be the same code that's used for synovectomy for infection. We thought those were fairly different as we tried to review those. Going up to the hip, the big list is pretty similar. There are some hemiarthroplasties, there are surface replacements, which are labeled supplements in ICD-10. The total hip replacement is in the 0SR section. There are separate codes in CPT for an arthroplasty after prior open surgery. The revisions similarly can be an exchange of a modular head and or liner, conversion of just the partial hip replacement, the hemiarthroplasty, or revision of any separate part to another total hip. The infected ones are an implant removal and a spacer. The second stage are removal of spacer and reimplantation of new implants. All of this done as one stage, or all of this done as something for a fracture. The related procedures for the hip are excision of heterotopic bone, which again seems to fall under that removal of tissue therapeutic, and then some manipulation codes. Here's some images. For the partial hip replacement, it's just a metal ball that articulates against the socket. Obviously, nothing needed to be removed from the pelvis to revise this, and the femoral stem and a polyethylene liner. Here's a surface replacement, which is a cap on the end of the femoral head with a acetabular component, and they look rather different, the total hip on the right here and the resurfacing on the left. And just for the total hip, in terms of the revision, the head can be exchanged alone. The head and the liner can be exchanged classically to put a captured liner in. The head, liner, and socket can be changed, and the stem can be left behind, or any combination thereof. This is a proximal femoral replacement, usually for tumor or for fracture. Obviously very different from a primary joint replacement. And then our goal, obviously, is to differentiate the revisions that are just a femoral head change from a polyethylene head change, so that ultimately we know whether one of those works dramatically better than the other, especially for the registries. And if so, we've made a proposal for that. And then the differentiation between static and articulating spacers. And then resection of heterotopic bone, whether there's just a better code for resection of tissue therapeutic. Obviously, my goals are a little bit wider than some of the specific things that we've put forward, but we're sort of tidying the coding house for arthroplasty and making it more granular for the benefit of the coders, the registries, and the hospitals. We've tried to enlist Nellie's help, and we've promised to help her by educating our surgeons. And since I represent ACUS and I've taken care of getting them through the introduction of ICD-10 CM, I think we can do this portion and encourage them to have a small portion within their operative note that has a table that indicates which implants were removed and which ones were reinserted, and I think that'll make life a ton easier. Thank you for your attention.
Are there any questions for Dr. Voss?
Lynn Keene, I have a question about the articulating spacer. Is the articulating spacer meant to be permanent, or is this one of the devices that would be removed and then a permanent replacement would be performed?
The articulating spacers are classically put in with a finite lifetime. Okay, the ones that are made purely of cement, for example, the knee one that was on the image, will slowly deteriorate over time, and they're recommended to be in between 3 to 12 months. Alternatively, the implants that are have a femoral stem and a polyethylene liner are more durable, and I've had patients with those in for 15 to 20 years who've never gone on to have the second stage done. Okay, content with their function of the articulating spacer. And so there are really several different varieties, but it's a little bit different than the static spacer because most of the people don't tolerate the static spacer very long or very well.
So that articulating hip is meant so they don't have to go through another procedure, say they're elderly and they can function with that?
There are some patients that will opt that as sort of their best option. They'll say, look, I've survived my infection. This seems to work okay for me. So it's almost a revision with the first stage, ignoring the second stage. And those will be elderly patients or ones who think this is good enough for me.
And is that why the selection of replacement was chosen for where the articulating spacer would be placed, rather than placing it in insertion where the non-articulating generic spacer is now located?
I am so new to ICD-10 PCS coding that even recognizing the various sections of the book, I've learned a ton in the last year. But if you guys have a better place to put this so that it will be easier for coders, we picked it as best we could understand it. I've been a little stunned to learn how varied our coding needs to be. For example, the modular liner exchanges are over in 0SW, and the removal of implants are someplace else. I don't even know how all of that started. But if you guys have a better place, we're all happy to do it that way.
As Linda said, it's complicated. Who knew? Okay. Thanks for that information, though, about that the articulating spacer could stay, because that's important.
Yes.
Thank you.
Moderator, are there any questions on the line for Dr. Voss? Please open the line for questions.
All lines are now unmuted.
Do we have any questions on the line for Dr. Voss? Okay, hearing none, we can mute the lines and proceed to current coding options. Our current coding includes code the removal of a knee joint replacement or knee joint prosthesis, or the replacement of all or part of the knee joint with a prosthetic component using the device value synthetic substitute, and the most specific available knee joint body part values for the procedure performed, as shown in tables 0SP and 0SR, which are on page 27 of the agenda. Code the removal of a spacer from the hip or knee joint, or the insertion of a spacer in the hip or knee joint, using the device value spacer and the most specific available knee or hip joint body part values for the procedure performed, again in table as shown in tables 0SP and 0SH. Coding options include option 1, do not create new codes specifying additional detail for procedures involving lateral or medial unicompartmental unicondylar knee replacement, patellofemoral knee replacement, or articulating spacers. Option 2, for the partial knee joint replacement, in the lower joints body system, revise the device value synthetic substitute unicondylar to synthetic substitute unicondylar lateral. Add new device values synthetic substitute unicondylar medial and synthetic substitute patellofemoral to the root operation replacement. That would be table 0SR, and the root operation removal table 0SP for the knee joint body part values. These changes would enable us to capture the additional detail for partial knee arthroplasty procedures as described by Dr. Voss. Option 3, for the modular femoral head exchange, in the lower joints body system, add new device value modular head to the root operations supplement table 0SU and the root operation removal table 0SP for the hip joint femoral surface body part values. These changes again would enable us to capture the additional details for subsequent hip arthroplasty procedures in which the modular head is exchanged. Option 4, for the articulating spacer and hip and knee joint, in the lower joints body system of the medical and surgical section, add new device value spacer articulating to the root operation replacement table 0SR and the root operation removal table 0SP for the hip joint and knee joint body part values. These changes enable us to capture additional detail for placement and removal of articulating antibiotic spacers in the hip and knee joints. We wanted to note to continue to code insertion of a static spacer using the existing device value spacer in table 0SH, insertion of lower joints, and that is depicted on the table on page 30. CMS recommends options 2, 3, and 4, and interim coding advice would be to continue to code as shown in the current coding described. Do we have any questions or comment? We welcome them.
Nellie Leon, She's American Hospital Association. First of all, thank you, Dr. Voss, for being so concerned about the hospital coding professionals. I wish that every surgeon, every physician that is documenting in the record would be as concerned about what the coders think. So thank you for taking the time to take this on. I just have a couple of questions that are really more from a coding perspective. The static spacer is also synthetic, correct? So really the difference between the two spacers is that one is static, the other one is articulating. So I'm wondering why there was a need to have the new value for the articulating spacer saying synthetic substitute, because I think it would be taken for granted that it's synthetic, unless I'm wrong. Is that right? Okay.
That is correct.
Nellie. I think
could you get to the microphone, because the people on the phone may not be able to hear you.
I'm sorry. The part of the difference too is that the static spacer is sort of made on the back table. The articulating spacer is pulled out of a box and is more like an implant. And the difference in work is that with the static spacer, I need to balance the knee, or the knee would wobble side to side wildly as they tried to move. And with the static spacer, I'm just trying to fill the gap. And so they're very different in terms of surgeon approach, patient function, and there's been a general trend away from the static spacer toward an articulating spacer. And I think those are a bit more expensive for the hospital too.
Okay, because I think that from a coding perspective, we would still need to revise the terminology for the current value, because a spacer, if it remains the way it is, both of them are spacers, so we need something to
They
differentiate.
are both spacers.
Right.
You are correct.
So we need something to differentiate the two values, otherwise there's a bit of an overlap.
Okay.
So I didn't know what the correct
Okay, well, I
terminology
think
would
it
be,
might
whether
be
it's static or
to,
some
if
other
we
term.
call the original spacer comma static, I think we'll have solved that, and I thought we had that in one of the proposals.
Okay, thank you.
Thank you for your comment, Nellie. We have additional comments on the floor.
Lynn Keene, Keene Consulting. I hesitate to bring this up because this could cause probably won't stop me from bringing it up. I'm in favor of 2 and 4. Number 3, I believe, has a problem. The device values that are included here in the supplement table actually have, the resurfacing device has, since its development, violated the definition, because as you showed in the picture, the resurfacing device actually takes out some of the femoral head, although not a lot. And when you look at the replacement root operation, it says that it physically takes the place and or function of all or a portion of a body part. And this is extremely confusing for coders, okay? That this really is not a supplement. This resurfacing device should be in the replacement, sort of like a mini. It's a small but important replacement because it has the acetabular component. So when we then mix in the device value of modular head, we kind of have this same problem, that we are really leaving the stem in place, and the head got damaged in a 2-part device on the femoral side. So this is different than going and adding something additional to an existing replacement piece that's already in there. And so I see you wanting to comment, so please help me with that.
You're absolutely right. Okay. I wasn't around when this got banished to the supplement category. I think the initial wish was for us to be able to distinguish the outcomes of surface replacement from a primary total hip replacement. Okay, and I think at the time this was the easiest way out to make this a unique code. If we want to bring it back, it's okay to put it with the rest of the total hips, but we should label it as slightly different so that it's distinguishable from a routine total hip, because when I'm old, I'd like to know which one of those is better.
I would too, and so, yes, but if it was called a resurfacing device and it was in the replacement table, it would really correctly identify the differences in the 2 pictures that you showed on the screen. Mm-hmm. And so my point in bringing that up was, if we add the modular head to that table, all we've done is confuse it even more.
I'm all ears to help put it right in the right neighborhood.
Resurfacing device, I think, goes in the replacement table, and the modular head would go in the revision table, because the stem
stays.
Right,
in OSW, yes.
In the OSW. Is there OSW? Thank you, sir.
You're speaking my language.
Thank you so much.
Thank you for your comments, Lynn. Yes.
Teresa Rahanic, Intelligent Medical Objects. I just wanted to point out a concern about retitling values within the system. So the change from L, synthetic substitute, to unicondylar to synthetic substitute unicondylar lateral. We keep renaming codes, so then they're not consistent. So procedures that have been coded with unicondylar with the L for the past couple of years, when you look at the data across, you won't see you'll think it was all lateral from the past year. So we continue to reuse and rename things. We did that last year with all sorts of body parts. So there's a concern there. And then in the existing PCS tables, we have body parts for knee joint femoral surface, knee joint tibial surface with laterality, do those codes need to go away if we implement or those body parts, are they going to capture something, since we're being more specific within the device for the type of partial arthroplasty device, unilateral, unicondylar? Are those body parts still meaningful in the tables?
They may be for other procedures, so they wouldn't go away, not for other procedures.
Okay. Thank you.
Does that make sense? Thank you. Are there additional questions on the floor?
Sue Bowman, I think Lynn mentioned this earlier on, but I didn't want their comment to get lost in all the comments that have occurred since then. But I'm also confused in option 4 why we're putting the articulating spacer in the replacement table and the static spacer is in the insertion table, and why they wouldn't both be in the insertion table.
Thank you for your comment, Sue. Moderator, will you open the line for questions?
All lines have been unmuted.
Are there any questions on the telephone line? Okay, hearing no questions, we will mute the line and go back to the floor for an additional question or comment.
Thanks. It's Linda Holtzman from Clarity Coding. I have to say this was kind of overwhelming, hard for me to take in, especially since I initially read it on the Beltway when I was stuck in traffic. So I'll be stuck in traffic leaving tonight, so I'll read it again. But were you, in one of your slides, I wasn't sure what you were trying to say in most of your slides, but I'll look at them again. But in one of them, were you intending to imply that a total hip or a total knee revision has to use multiple codes for each of the different components?
No, that wasn't the goal at all.
Good.
The challenge is there are so many different versions of the revision that it's hard to identify who's who for the hospital that's booking the case by the ICD-10 code or by the registry that's trying to figure out what was actually done. So if I go in and I say, you've worn out your plastic, I'm going to go in and remove the tibial liner, the tibial insert, and put a new one in. That would take maybe 40, 45 minutes. And I'd put in a new insert. Your recovery would be pretty easy. Hospital stay would be short. If I go in and change all of the parts, that's radically different.
I understand that.
Okay.
I seem to get, and I might have misinterpreted it, but I seem to get the impression that you were saying that if you do a total hip replacement, that you have to use like 6 codes for all the different components. No, it's one code.
No.
It's just
it's one.
Hip.
It's one. It's a hip.
Okay.
Yes.
All right, thanks. I didn't quite understand that. Also, just a general comment, actually, to you, Ms. Joshua. I just wanted to reinforce that you made a comment about how it's a lot of extra work for the physician. The physician has to do this and that. That's a focus of CPT, but it's not particularly a focus of ICD-10. ICD-10 is a hospital system. So just to bear in mind that although obviously the two are contingent on each other, what happens in the hospital depends on what the physician does. Something could be an enormous amount of work for a physician, but be essentially a breeze on the hospital side. So I just wanted to point out that distinction.
Part of the reason I mention it is that our hospital assigns us OR time based on what we've scheduled. Okay, and if I have a 45-minute case that they've put into a 3.5-hour slot, I'll get 2 surgeries done that day rather than 3 or 4. And so the hospitals use this to allot OR time. It's not how much money is involved.
And using the ICD-10 code to allot that?
Yes.
Okay, thank you. I didn't understand that point. Thanks.
Are there any additional questions? Okay, we will move on to the next agenda item, and Ms. Maddie Hui will introduce the next topic.
Hello. We're on page 31 of the agenda and handout packets. We're going to discuss endovascular thrombectomy of intracranial and extracranial arteries. Currently, the classification does not distinguish the major techniques used in these types of procedures for acute ischemic stroke, and you may recognize this proposal. It was presented back in March of 2017, and due to the comments that were expressed during that meeting with some of the coding options and the difficulty, we're bringing it back. The proposal's been revised, so I'd like to introduce Dr. Ray.
Thank you very much for giving me this opportunity. It's close to lunchtime, so I'll keep it to the point. You've been patiently listening for the past 2.5 hours. Continuing with a theme that was earlier presented about plumbing, it's exactly in that vein. No pun intended. And it's about unblocking a pipe. There are 2 ways to do it, and that's what I'm going to talk about. We know stroke is a big medical problem, not only in the US, but in the world. Almost 1 million people suffer stroke. The vast majority of these are ischemic, meaning the blood flow is blocked to the brain. That results in paralysis, that can be transient and in unfortunate cases can be permanent. The symptoms occur of ischemia because of the blocked pipe. The pipe that is blocked or the blood vessel that is blocked can be the main blood vessel or the smaller one. Most of the devastating strokes that result in the largest morbidity, mortality, and cost are the large vessel strokes, the big pipes that are blocked. And anatomically, it's given here. It's the internal carotid artery, the middle cerebral artery in the front, and the basilar artery in the back. We've been using TPA since 1995. It is approved up to extended window of 4.5 hours. Recent 7 studies, clinical trials, starting from 2014 to last year, have shown that TPA is less effective for the large vessel strokes, for the big pipes. The endovascular treatment comes in those large vessels. I've been fortunate for my career that I've been part of these trials starting 2003 and seen the evolution of these devices. The first one was the Mercy device in 2004. And in terms of the 2 categories of cleaning the blood or opening a blocked blood vessel, this follows in the category of stent retrievers or devices that are used to remove a blood clot. So if you imagine a clogged pipe, you can have a metallic brush and pull it out. This is in that one category. And now it's been superseded by newer technology. The second technique, again in the same analogy, is just sucking or pulling or aspirating the clot out without deploying a plunger or a device or a stent retriever. So aspiration, stent retriever, thrombectomy. The penumbra catheter system is approved, as is the new Riptide system that got FDA approval. It's made by Medtronic. Penumbra is made by Penumbra. And currently there are 3 or 4 stent retrievers that are approved in the US. There's 8 in Europe. So this is a modern stent retriever. It's a metallic cage. The red bits on it are clot that has been extracted from a blocked blood vessel. This is not a permanent implant. It's a retriever. It's a metallic retriever. It goes in, grabs the clot, and we pull it out. Trevo Solitaire, FDA approved. The other one, I think, is Mindframe, which is a smaller Solitaire. Now, whenever we do this procedure, and again, if a pipe is blocked, when we use the stent retriever or the metallic device, we turn off the main to the pipe. So we block the carotid artery in the neck, which stops forward blood flow. When we pull the device back, we pull back from the big catheter in the carotid artery to reverse the flow, so any debris that is fragmented doesn't go distally or flow upstream in the brain, it comes out. This is how we started doing the Mercy procedure, but it is used in conjunction with the stent retriever. In aspiration, which is without the stent retriever, you don't use this device. You just use a catheter to go in and aspirate and try to remove that obstruction. So one uses a stent retriever, which can be used with or without aspiration, and one uses just aspiration. So in terms of our op reports or documentation, we document that. I mean, the last week, so for example, I had 4 cases. 2 of them were complex. In one of them, I used, couldn't open it up, so we used the balloon guide catheter. We used another catheter for aspiration, and I used a stent retriever. In the other case, I just used aspiration. It was also complicated, but I could go by with just using aspiration or suction. And so that's the main differentiating feature. That use of aspiration catheter stent retrievers, they're documented in our standard reports. The thrombectomy device is always documented. We currently have 2 that are most commonly used. And to me, why this is important is in the country, we have all these kinds of techniques now, and people use the stent retriever or the aspiration. Both are commonly used, but if I go back and look at our data through our society and see out of the 25,000 stroke procedures done last year, how many were aspiration and how many were stent retrievers, I have no way of knowing, unless I review every single report, op note. So the main issue is differentiating between these 2 techniques to open the blocked blood vessel. There is obvious need for data specificity because that has implications going forward in terms of cost, which device works better, how are these techniques evolving. And tracking differences and outcomes by our largest databases. Our Society of Neurointervention Surgery has a database, a registry, that we track procedures, but we cannot separate them into these 2 categories. I will stop here. As I said, I'll be brief, to the point. Any questions, I'm happy to answer. Come on, I know there's got to be one. Great.
Moderator, can you open up the phone lines, see if there's any clinical questions for Dr. Ray?
Phone lines have been unmuted.
Okay, we'll go ahead and turn to page 32 of the handouts. Under current coding, endovascular thrombectomy of intracranial and extracranial arteries is currently coded to table 03C, extirpation of upper arteries. On page 33, under coding options, for those of you that were here, you know that the previous proposal attempted to identify 3 endovascular thrombectomy techniques of the stent retriever, direct aspiration, and the combined. But it was felt that it would be difficult to consistently differentiate the local aspiration that was integral to the stent retriever thrombectomy from the combined techniques. So that's why it's being presented again today. So option 1 would be do not create new codes. Option 2 would be in table 03C that we would create qualifier value 7 for stent retriever to distinguish endovascular thrombectomy of intracranial and extracranial arteries using the stent retriever from other extirpation procedures. We would add this new qualifier to address the 4th character intracranial and extracranial artery body part values and the approach value percutaneous. You can see in your handout that the new value would be assigned whenever a stent retriever is used for thrombectomy, either with local aspiration as an adjunctive part of the technique, or when the stent retriever is used together with direct aspiration. The existing qualifier value, Z, no qualifier, would be assigned whenever direct aspiration alone is performed as the primary technique. And we are recommending option 2. Do we have comments or questions from the floor?
I'm okay with option 2, but when as a code read stent retriever, we thought that you actually retrieve a stent. So there need to be some different wording for us to understand. What do you think, Linda? We need better wording.
Okay, do you want to submit that in your written comments?
So, Tina, actually, I need to disclose that I worked on this proposal, and you may remember that the last time this was here, I stood up here and complained about the previous proposal. So I worked on this one, and I think part of I mean, you'll hear this called a stent retriever. I mean, that's what you'll read in the operative report. You're right that the word stent can be confusing, but that train has already left the station. People use the word stent all over the place for everything. So this will specifically be called a stent retriever in the op report. That's what you'll read. That's what's here on the table. Hopefully that won't be too confusing. I think what we really need is, and I guess I'll pass the ball to Nellie, is that we'll have to have some kind of educational material pointing out that just because you see the word stent, maybe 10 years ago, you could assume it was a dilation stent. But that's not the case now. I mean, sometimes you see coil retention stents. They're not there to dilate the vessel. They're there to hold the coils in. You know, and there's all kinds of other, you see stent grafts that are, like, we just had the proposal on fenestrated endovascular aneurysm repair. And you put the stent graft in, then you put stents into the renals or whatever. Those stents in the renals, they're not there to dilate the renal. They're just there to provide, you know, some means for the blood to get into the renal artery. So this is a larger issue with the word stent, and I think the only way to address it is to have some kind of educational materials. Talking about just because you see the word stent doesn't mean it's dilation. Here's this kind of stent, that kind of stent, this kind of stent, that kind of stent. You know, and then as people discover more ways to use stents and put the word stent in there, we'll keep updating the article.
Not to have a debate here, but how about add in stent blood retriever something, that reactive material, just to be less confusing. You know, I can educate 10 of my coders, so now I can educate.
Well, the word stent will still be in there, right?
What is it?
This word stent will still be in there, whether it's a stent blood
okay.
retriever.
Yeah.
The reason it's, and Linda, I think, covered it pretty well, stent retriever is the generic device category. So to get away from it, I think you'll create a bigger omelet out of it if we try to separate it even more. Typically you'd use here the word stent retriever thrombectomy device, stent retriever. The word retriever will generally be after it. If it says a stent was implanted, like a carotid stent in a stroke, it'll be clear. All our op reports contain not only the word stent retriever, but they may also contain the specific type that was used. So this is agnostic to the different devices that are available.
Yeah, you'll see stent retriever in the documentation. The only reason this is called a stent retriever is because it you know, as you saw in the pictures, it has that mesh-like appearance. So somebody said, hey, this looks like a stent. Let's not talk to any coders. Let's just call it a stent retriever. You know, so, but that's the terminology that's in the literature. That's the terminology that's in procedure reports. You know, it is consistent.
And all the clinical trials use
right, yeah.
that. All the clinical trials that used, I mean, the recent Dawn, it uses stent retriever. Terminology is used in there, so.
Yeah, Nellie Leon, she's in AHA. Even before Linda volunteered us, I thought this, you know, I had marked my notes, this would be a good opportunity for Coding Clinic to educate the coders. I think it would be more confusing if you threw in artificial words that physicians do not use. So, you know, to call it stent blood retriever, you know, if that's not going to show up in the documentation, it will just be worse. So sorry. I think that Linda has given several examples of where we have seen stents used for different purposes. I think the other thing to keep in mind is that this is going into a root operation that is called extirpation. And I think that that will give you a clue that you're taking something out. And so this is different from your typical stent put in for dilation. So I would say in this instance, let's not confuse the coders by throwing words that physicians don't use.
Thank you, Nellie. Look forward to getting your written comments. Do we have any other comments or questions from the floor? Moderator, can you open the phone lines, see if there's any comments or questions?
All lines are now open.
Okay, thank you very much for interim coding. It would be to continue to code endovascular thrombectomy to table 03C. And I'm going to go ahead and turn it over to Michelle Joshua this time. Thank you.
Okay, so the next issue, topic on our agenda is robotic water resection of the prostate. Currently, there is no unique ICD-10 PCS code to describe the use of a robotic water jet to resect the prostate in treating benign prostatic hyperplasia. To present the procedure and describe that procedure is Dr. Eugene Kramolowski. Green button advances yourself.
Thank you. Hello. Thank you for staying and not going to lunch, although I wanted to. We're going to continue the theme of declogging pipes. Yeah, your cerebral arteries are important, but if you're a guy my age, what's important is your prostate. So we're going to discuss this new FDA-approved method for opening up the passageway. So when I talk about unplugging the pipe, I'm talking about a different pipe. Here's my disclosures. I'm from Richmond, Virginia. I've had the pleasure to work on 2 of the studies that have been done with this device, and it's an engineering victory, in my opinion. Benign prostatic hyperplasia is very common in men, very uncommon in women. It starts at about 40 years of age and continues. Symptoms worsen as you get older. The symptoms are frequency of urination, which means you go more often, hesitancy, which means you step up to the toilet and you can't go, nocturia, which is very bothersome. I speak from personal experience, so getting up at night to have to go. And these affect a large group of men in America. Surgical options. The surgical options of the past are TURP, which is transurethral resection, again, opening up the pipe by scraping the tissue out. That uses electrocautery. More recently, we've been using lasers to actually vaporize the tissue, again, opening up the pipe. And then there are microwaves, radio frequency, and other treatments that try to kill the prostate tissue to open up, again, to open up the pipe. These are the current options. The guidelines for treatment are based in part on the size of the prostate and the symptoms associated with it. TURP and the TUIP, which is an incision of the prostate, are done for smaller prostate glands. Prostate enlargement is all about real estate. It's location, location, location. The prostate, I've seen huge prostates where the men can void like a racehorse, and guys with tiny prostates who can't get out a dribble because it's what blocks the passageway that counts. So the attack for the urologist is different depending on the size of the prostate. The size of the prostate dictates how much tissue has to be removed, how long the operation has to go on, and the risk to the patient. We want to try to shorten the operations and decrease the risk. The ablation procedure is the only procedure that doesn't use some sort of heat in order to kill the prostate tissue, and also is the only procedure that uses ultrasound to visualize the procedure. Just take a minute to go through how it works. I've been involved in multiple cases, and a transrectal ultrasound probe is placed per rectum after the patient's put to sleep and in the lithotomy position. Then they call it the handheld device, but actually it's an engineering miracle. It's a device that's passed through the urethra, and it performs 5 functions. It performs suction in order to remove water that's collected from the procedure and from putting the instrument in. It also has an inflow channel to fill the bladder. It has the fiber optics so that you can see inside the bladder and inside the prostate urethra. You can't use the fiber optics if you don't have a light source, so it has a light source so that you can see in the dark channel. And then on top of that, it has the power jets that actually do the ablation. The This is a diagram of what we do, and if I can get the marker. One of these must make it work now. There we go. All right, so this is the ultrasound view of the prostate, and what's important about this is the sphincters here, the bladder necks here, and you can see all that stuff on ultrasound. And this is the only procedure that actually gives you a view of the depth of the procedure, and this is the tissue that you want to have the robot remove. This is actually live footage of the procedure. This is the ultrasound visualization. This is what you tell. You move these. It's really pretty slick. You move these with your finger, and you can direct the robot to remove the tissue that you want removed. At the same time as you're doing this, you can do it both sagittally and longitudinally, and you can get, well, this is called a median lobe, where the prostate actually protrudes into the bladder, and you can instruct the robot to actually remove this tissue, which is the most obstructive tissue, and often the guys with small prostates, this is the part that blocks up ball valves into the urethra and causes an occlusion. We don't have a basket or a stent retriever to get that out, but we might after today. I learn a lot when I come to these things. So this is the two trials that have been done. This is an FDA-approved device. The first trial was a prospective double-blind randomized trial comparing TURP, which is the gold standard, to the ablation. 181 patients. There was 4 countries involved, 17 sites, and it was a study designed to evaluate the complications, efficacy, and find out if this procedure actually worked. Water 2 was when they did Water 1, they noticed that the patients that did the best were the patients who had large prostates, because they're the ones who have the hardest time with an operation, have the most complications, and they seem to do the best. So we decided to go for a second study which just took men with large prostates, 80 to 150 grams. Oftentimes these men, if they need prostate surgery, has to be done open through an incision with subsequent blood loss and higher risk of damage to surrounding tissue. There was 101 patients entered into that study, and there were 16 sites. That was done in the United States and Canada. We're going to go through the results briefly. This is the adverse events at 3 months from the first study. As you can see, there were very few CD4s. This came out to be a very safe study. We knew the TUR study data from the history, but this is the current TUR data compared to the aquablation, and it's very similar. The primary efficacy can be seen that the adverse events on the endpoints were for TUR slightly higher, but not and significantly better for the water pressure study, water pressure treatment, and the voiding symptoms improved equally. So it was definitely equal to the transurethral resection. When we analyzed the data, a subgroup came out, and this is a subgroup of the men with the large prostates, 50 to 80. We cut it off at 80, so there's no prostates any larger than that in this study. And again, you can see that the value's there, but this is the dramatic value that the aquablation did so much better in improving their voiding. This is the second study, and this is the aquablation study that was done on 101 men. Now you can see their prostate volume on average is 107. So these are the guys with the big prostates. This is compared to the literature because this was not done as a comparative study. But what's interesting is the length of stay for this procedure is a day and a half. The length of stay for all these other procedures is a week or plus. So this is a marked improvement in the larger prostates where the men have more difficulty with the postoperative period because of the extended procedure that needs to be done. So, in conclusion, I would like to say that we have a procedure that decreases the hospital stay, decreases the need for transfusion, decreases the operative time, and what's important to me and is yet to be completely established, it decreases the damage to surrounding tissue. You know, the Hippocratic Oath is do no harm. And if you're fixing something that just gives me getting up at night to pee, frequency, urgency, and I haven't had a stroke, and so I don't need my life saved, I just need to be able to have a better quality of life, it's got to be safe. And I think that this has proven that with this clinical data. Thank you. Oh, the next slide should say questions. There we go. That's the easiest slide in the bunch.
All right, I note that we have no questions in the auditorium for Dr. Kramolowski. Moderator, please open the line for questions.
All lines are unmuted.
Are there any questions on the telephone line? Okay. Hearing none, we can mute the lines and move on to the current coding. Current coding: facilities can report aquablation therapy used to resect the prostate with the following ICD-10 PCS code, which is derived from Table 0V5. And again, if you're following along, it's on page 35 of the agenda. The code is 0V508ZZ, destruction of prostate via natural or artificial opening endoscopic. Our coding options include two options. Option 1, do not create a new code for the aquablation therapy used to resect the prostate. You utilize the current code as described in current coding. The second option would be to create a new code in Section X, new technology to identify aquablation therapy used to resect the prostate. And this code request is associated with a new technology application for fiscal year 2019. CMS recommends using option 2, create a new code in Section X, new technology to identify the aquablation procedure used to resect the prostate. Do we have comments or questions regarding the coding options?
Teresa Rahanic, Intelligent Medical Objects. I think we can already capture this procedure with existing codes, capturing the destruction code you already mentioned, and then grabbing the code from 8EO for the robotic-assisted procedure on the trunk, rather than creating a new code.
Thank you for your comment, Teresa. Are there any additional comments? Moderator, may you open the line for comments on the telephone line?
All lines have been unmuted.
Are there any coding comments on the telephone line? Okay, hearing none, we will proceed to the next topic on our agenda, and that would be the administration of plazomicin. There is currently no unique ICD-10 PCS procedure code to capture administration of plazomicin. To present the administration of plazomicin is Dr. Pamela Hahn, and this is a new technology application. Thank you. Dr. Hahn?
Good morning, or good afternoon, I suppose. My name is Pamela Hahn, and I am a Director of Medical Affairs at Achaogen. Achaogen is requesting a new ICD-10 PCS code for the administration of plazomicin. There is no distinct ICD-10 PCS code that exists for use of plazomicin post-FDA approval. An NTAP application has been submitted, and a new procedure code will allow for complete, accurate, and up-to-date tracking and ensure data availability. In today's modern medicine, where patients have successful organ transplants, complex surgeries, and even cures for cancer, effective antibiotics are essential. Many of these innovations in modern medicine are under threat due to resistance, and we need effective antibiotics to sustain these advances. Extended spectrum beta-lactamase production, or ESBL production, is a common mechanism of antibiotic resistance. Carbapenem-resistant Enterobacteriaceae, or CRE, are bacteria that are resistant to carbapenems. If you look at the graph on the left, it shows increasing prevalence year after year of ESBL production in both the community and the hospital. Because resistance due to ESBLs has developed, hospitals are now having to use a class of drugs known as carbapenems, normally thought of as last-line antibiotics. However, if you look at the graph on the right, because hospitals are now using more carbapenems, we are seeing an increasing rate of CRE. This is why the CDC has listed carbapenem-resistant Enterobacteriaceae and ESBL-producing Enterobacteriaceae as an urgent and serious threat. These infections are increasingly rapid, There are limited or no treatment options, and they carry a significant burden to patients and healthcare systems because of the high morbidity and mortality. Plasmamycin is a next-generation aminoglycoside that is uniquely engineered to overcome resistance caused by aminoglycoside-modifying enzymes. It is rapidly bactericidal, has demonstrated activity against ESBL producers, CRE, and aminoglycoside-resistant isolates. Plasmamycin application includes 2 indications, one in complicated UTI, including acute pyelonephritis, and another in patients with bloodstream infection due to certain type of Enterobacteriaceae. Both of these indications are for patients with limited to no treatment options. Important to note, plasmamycin has received breakthrough therapy designation, QIDP status, and fast track designation for its potential to offer substantial treatment advantage over existing standard of care. If approved, plasmamycin will be the first IV aminoglycoside approved by the FDA in over 40 years. Plasmamycin is dosed at 15 milligram per kilo every 24 hours over 30 minutes in patients with creatinine clearance greater than 60. In patients with moderate or severe renal impairment, a dosage adjustment is required. It's expected to be administered primarily in the hospital setting and may be administered via both central and peripheral vein. As there are limited clinical and safety data, reserve plasmamycin for the use of patients with limited or no treatment options. Plasmamycin has also not been studied in pediatric patients. Like other antibiotics in the aminoglycoside class, the warnings and precautions for plasmamycin are nephrotoxicity, ototoxicity, neuromuscular blockade, hypersensitivity reactions, C. diff, and fetal harm. 2 phase 3 clinical trials were conducted with plasmamycin. One trial was conducted in patients with CRE infections, also known as the CARE study, and another one in patients with complicated UTI, including acute pyelonephritis, known as the EPIC study. The PDUFA date for plasmamycin is June the 25th. The primary objective of the CARE trial was to evaluate the efficacy and safety of plasmamycin compared to colistin in the treatment of serious infections due to CRE. The primary endpoint was 28-day all-cause mortality or significant disease-related complications. Study enrolled patients with serious infections due to CRE. Patients were randomized 1-to-1 to receive either plasmamycin or colistin-based therapy for 7 to 14 days. This slide shows the results of the primary endpoint 28-day all-cause mortality or significant disease-related complications, and a key secondary endpoint 28-day all-cause mortality. As you can see, plasmamycin was associated with a 39% absolute reduction in 28-day all-cause mortality or SDRC. And looking at the secondary endpoint, you can see the majority of these events were driven by deaths, where plasmamycin was associated with a 32% absolute reduction in 28-day all-cause mortality compared with colistin. Looking at the mortality at day 60, you can see the survival benefit was observed with plasmamycin at day 28 and was sustained over time with a higher proportion of patients, a higher proportion of plasmamycin-treated patients surviving out to day 60. In terms of safety, adverse events were common in this critically ill population. Plasmamycin was associated with a favorable safety profile compared with colistin, with reduced drug-related adverse events and adverse events related to renal function. There were no study drug-related deaths. The primary objective of the EPIC study was to demonstrate non-inferiority of plasmamycin compared to meropenem in the treatment of complicated UTI and acute pyelonephritis. The primary endpoint was composite clinical cure and bacterial eradication at study day 5 and test of cure. Patients were randomized 1-to-1 to receive plasmamycin or meropenem. In this study, plasmamycin achieved the primary efficacy objective of non-inferiority to meropenem. On day 5 and at the end of IV therapy, outcomes were similar between the two arms. However, looking at the test of cure visit, you can see the treatment difference of 11.6% in favor of plasmamycin. Consistent with higher composite cure rates at test of cure, plasmamycin also demonstrated statistically higher microbiologic eradication rates at test of cure compared to meropenem. The difference was even more pronounced at late follow-up visit, with a difference of 19% in favor of plasmamycin. Most importantly, the significantly lower microbiological persistence rate at test of cure in plasmamycin-treated patients translated to fewer clinical relapses at late follow-up at approximately day 28. As shown in this graph, meropenem-treated patients with asymptomatic bacteriuria at test of cure, 21.1% of these patients experienced clinical relapse compared to 0 patients in the plasmamycin arm. Looking at the safety data for this trial, the incidence of adverse events were well balanced between the 2 treatment arms. There was a slightly higher proportion of plasmamycin-treated patients that had adverse events related to renal function, which is consistent with known aminoglycoside class toxicities. These renal events were generally mild to moderate in severity and resolved by the end of the study. In conclusion, 2 indications are being sought for plasmamycin: complicated UTI, including pyelonephritis, and bloodstream infections due to Enterobacteriaceae. We expect plasmamycin to be administered primarily in the hospital setting via a central or peripheral vein. Complete and accurate up-to-date procedure codes will improve tracking and ensure data availability, and an NTAP application has been submitted for plasmamycin for FY 2019. Thank you for your time, and if there are any questions, I'm happy to answer them.
All lines are now unmuted.
Okay, hearing no questions in the audience nor on the phone line, we will break for lunch now and reconvene at 1:30 with the coding options for this, for this request. Thank you.
But we have a flight we both have to catch at 2:30, so, but I mean, we'll have to just stay.